Three, two, one. We are live now, sir.
Good afternoon, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intas Pharmaceuticals. On behalf of Intas Pharmaceuticals, I welcome you all in this Symbiosis Series Webinar 7 on 19th March 2024. The topic of the webinar is Endometriosis Unplugged. Before starting the webinar, we would like to play Sam Flight.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
Now, I would like to introduce Dr. Monica Singh.
Thank you, Dr. Vishal.
Dr. Monica Singh is Professor at Allen Medical College, Bhopal. She is Consultant Reproductive Medicine, Bhopal Fertility Endoscopy Center. She is Managing Committee Member, ISAR. She is also West Zone Coordinator, Medical Disorder Committee, FOXY. And she is convener of ISAR Perfection Series as well as convener of FOXY Symbiosis Series. Now, I would like to hand over the session to Dr. Monica Singh.
Thank you, Dr. Vishal, and greetings to Dr. Rishikesh Pai, sir, who has just joined us. Hello, sir. Good evening. We are delighted to have you with us, sir. And without wasting time, let us go to the introductions. Dr. Vishal. Our webinar today is with FOXY International Academic Exchange Committee, Chairperson Dr. Pratibha Singh, and VP North Zone Dr. Neeraj Bhatla have been very kind to give consent to being a part of Symbiosis. We are on episode 7, and for this Symbiosis series, we are extremely privileged to have the blessings of FOXY office bearers who are amongst us. Rishikesh Pai sir is there. Dr. Madhuri Patel will be probably joining from the airport. Our dynamic president, Dr. Jaideep Tank, Vice President, Madam Dr. Neeraj Bhatla, and Chairperson, FOXY IAE, Dr. Pratibha Singh.
Thank you.
So I will keep reading the CVs as the dignitaries join. And Dr. Jaideep Tank sir is President FOXY, and because of him, we are proceeding with the series very nicely and very successfully. Dr. Madhuri Patel is yet to join. To Purnima, you can give Madam a call.
Madam is joining, ma'am, from airport.
Okay, Madam is Secretary General FOXY, and I think because Pai sir must be short of time, we can straight away come to the CV of Dr. Rishikesh Pai, sir. Can we have the CV of Dr. Pai? Our chief guest for today is Dr. Rishikesh Pai, sir, and I've been troubling him since I think a month. But he said, Monica, you must remind me 1 hour before the program. So we had just had a chat a few minutes back. We all know how he has steered FOXY successfully in the past 1 year and for a decade before that. And now we are very proud to say that Sir has stepped into international waters. And he's basically now, you know, a world-known, renowned figure as trustee for FIGO. And he and Rishma ma'am are planning a very good fusion conference in the pink city of Jaipur very soon. We are very excited about it. And we know that he will get together all the best organizations in India and collaborate with ESHRE and ASRM to have this, great conference. Sir, we cannot wait to hear from you. We need your blessings for today, sir.
Thank you, Monica. First of all, let me congratulate the FOXY International Academic Exchange Committee headed by a very dynamic chairman, Pratibha. Even before she became chairman, her Zoom meetings were very popular, and she did fantastic work during her first year. We went to UK and then we went to Paris. And, this year also we are going to Busan, and then where is it? Pratibha? Next is where are we going?
Oman we are going.
Oman, yeah. Oman. So Oman is for the RCOG, right?
Yes.
So basically, and I would like to, of course, congratulate Monica. She is very dynamic, has just got into ISAR, and wish you the very best for your future as well. And of course, I would like to pay my respects to Dr. Jaideep Tang, our president, very dynamic president, Dr. Madhuri Patel, our secretary general, and Lakshmi is there, who has been a very good ICOG chair during my tenure, very nice, and we had a very good symbiotic relationship, kind of, and I'm sure that Parag will be following her footsteps. I can see him also, the present chair, chairman-elect is, no, you're the chairman-elect, right? Parul is the chair at present. And then, of course, we have got other people in the audience. They are here. That we have Dr. Panda, who is a president, and I would also like to first recognize the president of the Bhopal Society, Dr. Anita, and the secretary, Dr. Shabana. So they are very important for us. Our society, we run in a particular system. At present, we have 277 societies and 43,000 members. And then we have our Vidya Thobi, who is the president of was the immediate past president, no, Vidya, of the Kasoga. At present, she is the Bharti, and so we have all of the Dr. Jitendra Panda, who is our president from I think Orissa, and then we have, of course, the great Dr. Randir Singh, who is
Namaskar.
so
Thank you, sir. Thank
a
you,
very
sir.
dynamic embryologist and a clinician as well. I think both of them to put together. And so there are a lot of other people. I can't keep on taking the names, but basically I just wanted to tell you that this year is a very hectic year. We have got multiple conferences that are coming. Sujata Kar has just joined us. So multiple conferences are coming up. The first conference that is about to come is the conference in actually not today. It's a very fortunate day for me because today is the trustee meeting of the FIGO, just now in the evening at 7:30. So the first trustee meeting was in December in London, and now this is a Zoom meeting. And so we are having a lot of meetings that are coming up. Mainly the Busan meeting is there, which is for the EOFOG. And after the Busan meeting, there is of course, some of them will go to H3, etc. But there is an important meeting that will be coming up after our president, Dr. Tank, is having meeting in November. So in the end of November, we have a meeting which is the regional meeting of the FIGO. So FIGO has two meetings. One is the annual meeting, which next meeting is in Cape Town, that is in October 5th to the 9th of October in 2025. But there's a regional meeting, and that regional meeting is in Bali just this year from 24th to the 29th. So 24th and 25th is the trustee meeting, and from 26th onward, the meeting will be there. So if some of you are interested, for this meeting, I will of course talk to Pratibha about it, but we may take a group to the Budi Viveko, my very good friend, and he's the present president of the Indonesian Society, will be doing this meeting for the FIGO, and the entire FIGO leadership with all the we have 17 chairs, committees, and now we have today is a very auspicious day because we are adding 5 new committees to FIGO. So the total committee number will be 21 committees that will be there. And I'm sure many of you will, as we go along, because our system has been now streamlined. So we now have a democratic process of elevating all of you into the committees, and that is very good. So they have got what is known as, every committee has got 8 members, and there is a gender balance, that is 4 women and 4 men, and there is also what is known as the regional balance. So regional balance and gender balance is maintained. So it's very good for all of you as we go along. More and more of you, our chairmans, our vice presidents, all will go into the international scenario. So and then of course we have the All India Conference, which is there in from the 8th to the 12th of January. That will be in Mumbai. And I would like to request all of you, all the important people of each of your societies, you need to give me the name because we are now doing the program in advance. So by June, I will finish the program for the conference. So everything is going as per plan, touch wood, and everything will go. We are expecting about 12,000 people. We have already booked Sonu Nigam today. And because it was either Arjit Singh or Sonu Nigam. There are no other great singers in India. So Arjit Singh is too costly for us, so we had to settle for Sonu Nigam, but he is equally good. Many people were, in fact, I asked them, what is a better person? They said, we like Sonu Nigam more than Arjit. So I'm very excited that we have got Sonu Nigam. and he has confirmed it. And the second singer, again, we have to have gender equality, so whether to have a female or a male singer is the problem. But we are very excited. The meetings we had a photo session just yesterday. We had all the seniors. We missed Madhuri for that photo session, but all the seniors, all our past presidents were there. Dr. Usha Krishna, Saraya, all the Sadhna Desai, all of the cluster presidents, where we had a photo there. And so this is one occasion when you bring all the people of Mumbai together. Mumbai is a large society. And so I don't want to waste your time. I'm just excited. I want to share with you my excitement. The venue is I think the best venue in the world. Ambani has made a beautiful venue. And when I went yesterday to the venue, they had closed down the 3 halls because Anand's, the son's wedding is there. So they have closed the halls for renovation. So we will get the renovated halls. So if the wedding is in June or July, so they are closed all the halls for renovation for the wedding. So and our meeting will come after the renovation. So I'm really excited that how they will renovate the hall. So thank you very much for calling me. Dr. Nija Batla has also joined, our great vice president, and she's done fantastic. About Dr. Batla, he is so famous that even in the international thing, she's famous, and she's now one of in the Stud Volume 7, where I've contributed a chapter. She is the editor of the Stud Volume 7. That high level she has achieved academic excellence, and very well known in the field of HPV vaccination. So it's a privilege to have her amongst our midst. So thank you very much, Monica, and wish you all the best for the president's session. Thank you.
Thank you, Dr.
Thank
Pai.
you. Thank
And your words are always electrifying. Means
And,
you
and, yeah, and
you
thank you,
energize
Pai sir. And thank you,
everyone.
Pai sir. Sir, you are always lucky. So you're getting all renovated best venue of the world. So we'll make a great success at Mumbai AICG 24.
We have
25.
all of you have to come, and we have made
Yes, sir.
11 halls, and
Yes.
I'm sure Dr. Madhuri is going to help me with the scientific chair placement also.
Yes,
Thank
sir.
you,
Yes.
sir. Thank you. Dr. Madhuri Patel is with us, Secretary General Foxy. Madam, would you like to speak a few words?
Definitely. I'm so sorry, Rishikesh and the entire team. I'm at the airport and Monica just now called me that please join. So, respected our Dr. Rishikesh Pai, my very, very close friend, and we had a wonder time, in his presidential year. And I still remember it, that how, we were very active. Now also I'm active, but I had a real wonderful time traveling to all the societies and giving messages. Then our Jaideep Tang, President Foxy, then Dr. Nirja Batla, who is the Vice President in charge, and then Dr. Pratibha, very vibrant. Last week I had been to Dhanbad, and the way they have done, all the, Bihar and Jharkhand State Conference, fantastic. And Pratibha is VP of that, state. So Pratibha, congratulations to you. And then we, of course, have Dr. Anita, Dr. Shabana, Dr. Manisha, Dr. Monica, Dr. Ranveer, then we have Dr. Jitendra, Lakshmi and Paragar, our today's, guest of honor and chief guest, Dr. Rishikesh Pai, whom we heard. And, I can see Dr. Vidya and I can see Dr. Sujata. So, and other people have logged in, but I can't make out their faces because their video is off. So all dear friends, very good evening to all of you. This endometriosis has really created a problem for young girls as well as the elderly people, because nowadays the girls are getting married very late age, and we see by the time they plan for their pregnancy, they are with the severe dysmenorrhea, severe pelvic pain, and their tubes are gone, ovaries are gone. So it creates a very, very bad situation for them. And sometimes we see this girl with a frozen pelvis. And I remember infertility is such a severe problem in the endometriosis that we hardly do justice. But now we are coming out with all the, Sujata is going to talk about the surgical management in case-based scenario. Pratibha is going to talk about X-ray guidelines. And of course, Dr. Avashom is going to talk about the biomarkers of the endometriosis infertility. So it is really going to enlighten us about the topic, and it will help us in our day-to-day practice to benefit our women. So with this, I'm not taking much time, but I congratulate the team, Bhopal and our team, Foxy, Pratibha, Nirja, Jaideep, Rishikesh for, most apt webinar, and I wish them all the best. So thank you very much for inviting me for this occasion. Thank you.
Thank you, Madhuri ma'am, and thank you make it a point to join even when you're traveling. Your words are so encouraging to us, and they make us, work harder for Foxy. With Foxy,
Thank,
always for Foxy. Uh,
thank you.
Thank you, ma'am, and
Thank
have a safe journey. And now I would like to welcome our VP North Zone, Dr. Neeraj Batla is with Dr. Neerja Batla is with us, and I have just gone through her CV. It is so illustrious that I just don't know what to say. She is the star from AIMS Delhi, and she is a well-known figure all over the world. Her work on cervical cancer, HPV, is phenomenal. I'm sure all the students who must be studying under her are blessed students to get her presence and her wisdom all the time for the 3 years of postgraduates, even her undergraduates. So, madam, we are blessed to have you amongst us, and we cannot wait to hear your words for this webinar and your opinion about endometriosis in general. Welcome, ma'am.
Thank you so much, my dear Monica, and thank you to all the others for the kind invitation. Dr. Manisha, Dr. Shabana, my dear Dr. Pratibha, and Dr. Rishikesh for his very kind words and the passion with which he works. See, I have not directly worked with Rishikesh, but Rishma was my president. So it was a very good and close association we enjoyed, and it was so productive. So, Rishikesh, you bring so much enthusiasm and passion and simplify the whole story. And it's always very nice. And we are looking forward to Mumbai for sure. And Dr. Jaideep, Dr. Madhuri, it's a wonderful team we have with my other co-VPs. And we are really happy to see the work. And Pratibha is one of the most enthusiastic. Ye to 12 घंटे में she turns out a webinar, she doesn't even wait for 24 hours to be over. So it's always a pleasure to see all the dynamic work going on. And Dr. Lakshmi and Dr. Parag, also very highly motivating always and so involved. Dr. Vidya, my best wishes are with Vidya always, and so many other good friends I'm seeing. I'm not naming all. But endometriosis truly, it is increasing. It is coming younger and younger. We used to say the women who delay childbearing, now we see even in younger people. And it is a disease which is benign, I feel, only in name, because it has all the characteristics of malignant. It is locally invasive, it is recurrent, it is highly debilitating, highly painful, highly symptomatic, psychological implications, so many implications, and requires an extreme challenge for those, as Dr. Madhuri said, who still want childbearing. It requires great technical expertise. And on the other hand, we get so many drugs are coming, and we don't really know why it's increasing, what exactly is happening in molecular level. But some people say it's even being aggravated by our pollution, which is causing some xenoestrogens to be present in the air from all the pollutants that are there in these particulate matters and all of that. Some people blame the dairy sources also, that we are getting so many dairy sources with hormonal injections being given to the animals and so on and so forth. So lot of scope there for really figuring out why it happens. But bottom line is that there are a lot of advances, lot of new drugs, lot of new techniques, MIS getting better and better and so on. So we can offer hope. And so it's very important to stay abreast. So I congratulate you all for choosing this topic and wish you all the very best.
Thank you, Neerja ma'am. Thank you so much. And it was really enlightening to hear your concept about xenoestrogens in the pollutants and the dairy products. That just gives you another avenue of, treatment and advice to our patients till it becomes evidence-based, of course, and we expect a paper from AIMS. Madam, now I would like to invite Dr. Pratibha Singh, who is our chairperson of the Foxy International Academic Exchange Committee. And because of her vision, we could get key speakers, and we have Professor Zheng from Taiwan would be joining us at 5:30 p.m. So, madam, a few words from you, please. Pratibha ma'am.
So, good evening, everyone.
And today I'm really very happy to be the part of this very important webinar, the Symbiosis series of endometriosis. And I extend my gratitude to our President Foxy, Dr. Jaideep Tang sir, and Secretary General Dr. Madhuri Patel ma'am, and my VP in charge, Dr. Nirja Vatla madam, for their constant guidance and constantly motivating me to do good work. So thank you, madam, for always being beside me. And my respectful regards to our chief guest, a very pleasant personality, a dynamic past president Foxy, Dr. H.D. Pai sir, under whom I have learned so much. So welcome, sir, and thank you so much for such encouraging words. And our guest of honor, Dr. Lakshmi Madam and Dr. Parag Binewala, thank you for joining. And we have wonderful sessions today lined up. And this month is the endometriosis month. So we are looking forward for a very informative talk by our international faculty from Taiwan and Dr. Jeng on biomarker in endometriosis and its importance in infertility. And a talk by Dr. Sujata Kar Madam will inspire us to improve our surgical skills on endometriosis associated infertility. Also, we have a panel on endometriosis. So my respectful regards to all the esteemed faculties who have joined today for this program. And my special thanks goes to Dr. Monica and Dr. Randhir Singh for organizing this webinar under the IAC committee, FOXY. And Monica, along with Dr. Manisha, who has worked meticulously to plan this webinar, and on every small points they were asking me, and I'm really very happy. And I'm sure that it will be quite enriching for all of us. And once again, I want to congratulate Dr. Monica for organizing such wonderful knowledge sharing webinar. And I also want to wish her all the best for her future endeavors. So our blessings are always with you. And thank you so much for giving me this opportunity. Thank you.
Monica, 1 minute before because I have to leave, but I wanted to tell you, yesterday I got an email. So these SNPs that are there, the biomarkers. So now you can take them, and Dr. Philip DeCamp has done a lot of work he's the vice president of FIGO last time, and he has done a lot of work on this to diagnose endometriosis through SNP. But yesterday, what excited me was this email has come from a company in United States where they are using the SNP to exactly pinpoint the window of implantation. So your ERA test now will go away. So you just take the blood and find out exactly when, using the SNP, you can find out which day you do the embryo transfer based on the receptive analysis. So the SNP from the endometrium, they pick it up from the blood. So they want to have a meeting with me to bring it to India. So it was very, very exciting, what breakthrough science are coming up with. That's all I wanted to say. Thank you.
Thank you so much, sir. And I know your enthusiasm is infectious. I mean, to say the least, when you go on stage and speak about something, we all want to, watch you doing it and emulate you. So congratulations, sir. And thank you for giving us that interesting bit of information. I'm sure you are very, very friendly with genetics, SNPs and everything, and you'll get the technique to India very soon. Thank you, sir.
One more thing.
You are muted.
One of the companies has come out just now so maternal contamination is a big issue. So whatever tissues you pick up, say when you do fetal DNA analysis for NIPT, maternal contamination test is very important to see that DNA is not from the mother and it is from the embryo or from the amniotic fluid analysis, mother contamination. So new test has come also for maternal just in the email just now I was seeing it. So they have come out with I can't take the name of the company, but they have just come out in India with that new test. Even in product of concept test, there's a contamination. You may take the mother tissue. So now utilizing DNA and linkage analysis, you can be sure that what you're testing is the fetal origin and not the maternal origin.
Yes, sir. Yes, that's right, sir. Thank you so much for that information. And now, with Pratibha ma'am's permission, I would like to welcome our guests of honor. Dr. Lakshmi Srikhande has been there right from the beginning. Madam, are you there?
Yes, I am very much here.
Madam, we are waiting for your, words for this webinar and your words as guests of honor, please.
Thank you, Pratibha. Thank you so much. And after hearing the electrifying speech from our today's chief guest, Rishikesh, I must salute you. I mean, you are always in forefront, whether it is technology, whether it is leadership. I mean, you are always there and always energetic. And I really enjoyed working with you as ICOG chairperson, and your vision for the ICOG was simply commendable. So hats off to you, Dr. Pai. And now we are so happy to see you in international forum, and there also इंडिया का तो झंडा गाड़ने ही वाला है हमारा ऋषिकेश. We are so happy and proud to see you at FIGO and all the international bodies. So today's chief guest, then our dynamic president Jaideep Tank, he has taken over just 2 months back, and the amount of work he has done in these 2 months is really mind-boggling. Our first Lady Secretary General Madhuri Patel, Parag, chair-elect of ICOG, who is guest of honor with me, and I can see all the luminaries here. Pratibha, who is doing wonderful work, and Nirja, what to say? Rishikesh has already said about Nirja, so I don't want to repeat, but I fully echo whatever he has said about Nirja Bhatla, and all our esteemed faculties who are there, and Pratibha, and the couple, the firebrand couple, Monica and Randir. Randir, I like. Rishikesh, did you notice what he has written? Dr. Randir Monica Singh. And I told Randir, you are not going to change it.
No, ma'am, I will not change it, ma'am.
Starting the new trend.
Yes, ma'am.
No, you are really
I think that
firebrand.
is true gender equality.
True gender equality. So I told him, don't change, keep it there, your name for the full webinar and rather the whole series.
Yeah.
You both are really doing wonderful work, whether it is ISAR, whether it is Foxy. You are always there, and your passion for doing the webinar series and to update our members about the latest things, happenings. And today you have come out with beautiful endometriosis theme, and you have chosen the speakers, the topics. They are simply fantastic. So I don't want to take much of your time as we are already behind your schedule. I want to thank the Pratibha, the Monica, and the Randir and the team Symbiosis for inviting me and making me a part of your Symbiosis series, and all the very best for your this webinar. Thank you.
Thank you, Lakshmi ma'am. And I have been a student of your certificate courses of ICOG. I was mesmerized. Madam has done some fantastic. Then I spoke in Bhopal Obstetric Gynae Society to all my colleagues. Please attend these courses. Madam, hats off to your academic passion.
To Dr. Pai, he was the Foxy ICOG president, and I must say that he was having his attention to the minute details of how ICOG is working, what ICOG is doing, and I already said it was a sheer delight to work with him as ICOG chairperson.
Thank you,
The ICOG we released that OSCE na, which is very good. That book, the red book which has come. Na?
Yes, OSCE, yes, handbook.
Yeah. Thank you, Lakshmi ma'am. And I would now invite Dr. Parag Beniwale, who is ICOG chair-elect, and I'm sure he's going to take ICOG to further great heights. He has been the president POGS. And
Thank you, Monica. Don't waste time in reading slides.
Yes,
That's okay.
so a few words from you, sir.
Sure. Thank you. First of all, thank you, Pratibha and team International Academic Exchange Committee, of course, along with the office bearers of Foxy, for having me here today. It's indeed a pleasure to share a virtual dais with very dear friends, Rishikesh and Lakshmi, whom I've been friends for more than 20 years now. And Rishikesh, I'm looking forward to coming to Mumbai because I'll be installed as the chairperson of ICOG in Mumbai. So I expect a lot of pampering from Team Mumbai next year.
आपको ऐसा बराबर क्या आसन पे डाल देंगे हम लोग.
And I must appreciate Monica, Randir, Manisha, Purnima, all of you. Fantastic work you're doing. And even last time when Monica and Manisha arranged one program, I was there, and they have periodic reminders and they make sure that you are there and you are reminded on time. So thank you for asking me to be here. Endometriosis is something which is once upon a time was thought to be disease of the West. I remember listening about endometriosis as a PG student way back in 1991 when Dr. Nargesh Motashaw talked about it, and we were really mesmerized. At the same time, we were really struggling as to what exactly it is, and we always thought that it was disease of the West, but now we do get to see a lot of endometriosis, and then the women are bothered throughout their life at different stages because of endometriosis. So I'm sure it's going to be a great learning experience for me. So thank you once again, and I look forward to a fruitful learning session. Thank you.
Thank you, Parag sir. And we are very honored to have you a guest of honor today. Always look up to you, sir, for your advice and mentorship. I would like to pay my regards and thanks to Bhopal Obstetric and Gynae Society, my president, Dr. Anita Srivastav, a very senior gynecologist from our city, and our secretary, Dr. Shabana. Shabana, would you like to, Shabana is a chairperson also today. Dr. Shabana, are you there? Would you like to speak?
Yes, ma'am. Yes, ma'am. Good evening, and thanks for making a part. I welcome all the dignitaries and a very important topic for today's webinar, that is endometriosis, because lots of many theories and lots of many guidelines for the management. It's a benign disease, although creating so many problems. So I am very much thankful to be a part of this webinar, and I am also a student of Nirja Batla ma'am for the ICO course. I want to mention this. Nirja ma'am, for the oncology course of ICOG fellow. I think Nirja ma'am must remember.
So Dr. Shabana and Dr. Manisha are very important team members of Bhopal Obstetrics and Gynae Society, and very soon we'll be seeing them in the national scene also because they are working very hard. Thank you, Dr. Shabana.
Thank you,
And
ma'am.
now I would just hand over the program to our coordinators. Dr. Manisha, you all know. Dr. Purnima, you all know. They are the arms of Foxy and Perfection and Symbiosis series. And they are the ones who keep me going, pushing me to do better, and they work equally hard. So now please start the sessions, academic sessions.
Thank you so much, ma'am. I know after the electrifying inspiration and talk from our president and all the senior faculties, I know we are all charged up and geared up for the academic session now. Our speakers are waiting, our delegates are also waiting. To chair the first session, we have Dr. Sujata madam as a speaker. And to chair the first session, we have Dr. Vidya Tobe madam and Dr. Jiten Kumar Pandas with us today. I welcome Vidya Tobe madam. Madam is already known to everyone. She's the president of Kasoga. She has been the chairperson of Food and Drugs Medical Surgical Equipment Committee and also received the Best Committee Foxy Award, Dr. Meru Lara and Sotia Award. She is currently the ICOG Governing Council member and has held various posts in different organizations, has been a national faculty and international conferences, presented many papers, and has immense teaching experience of more than 3 decades. I welcome you, ma'am, for today's session. Next, we have with us Dr. Jiten Kumar Pandey. Sir has been very generous to join from the beginning. He is the president of Bhubaneswar Obstetric Society and also presiding as IMA Bhubaneswar. Published many papers in international journals and magazines, and is a very senior and eminent faculty with us today. Over to chairpersons for the first session.
Thank you. Thank you very much. At the outset, I thank all the Foxy office bearers, especially Dr. Pratibha, who is a dynamic chairperson of International Academic Exchange Committee, as well as Dr. Monica, and all the dignitaries who have joined this webinar. So we all know that endometriosis is a disease of enigma, and always whenever the patient comes with infertility, we always have a problem when to operate, when not to operate, especially the stage 3 and stage 4. And then it becomes very difficult for the decision making. And the first operative, when we do the think of operation, so the first surgery should be the best surgery. That's what we talk of. And today we have got an eminent speaker who will be talking on this different strokes and for the different folks. The title itself is so nice. So we have our Dr. Sujata Kar, who is an eminent speaker on this. She is a practicing gynecological endoscopy and assisted reproduction for last 28 years. And she has got special interest in PCOS and proteomics of male infertility. And also she has some interest in the stem cell in gynecology. She is a gold medalist. We know her so many achievements, so many awards and publications. And at present, she is Secretary General of ISAR India. So over to Dr. Sujata Kar. Let us listen from her the different strokes of surgery in endometriosis. Thank you very much. Over to Dr. Sujata.
Good evening. Good evening. Good evening. Thank you so much for your kind introduction. Thank you, Dr. Pratibha, Dr. Monica.
Good evening, ma'am.
For giving me this opportunity.
Good evening.
I'll just share my screen.
Yes, ma'am, please.
Please, please.
You are really
One second.
looking beautiful in that purple dress.
Yeah.
That's my latest scrubs.
Looking
Yeah,
younger and
very
younger.
good.
Um,
Good.
Thank you so much. Okay. Is it visible?
Yes.
Yes, ma'am.
yes.
Okay. So my topic today is endometriosis, infertility and surgery, different strokes for different folks. So actually endometriosis is an ancient disorder. It has been mentioned way back in even before Hippocrates, even in the pre-AD, it has been mentioned. And we know that in our book, William Osler said, he who knows endometriosis knows gynecology. One of the best known sufferers from endometriosis was Queen Victoria. She was known for her menstrual blues. But she was also very fertile and she was known to treat her menstrual pain with marijuana and repeated childbirth. So she had got it absolutely right as to how to manage her dysmenorrhea and her severe pain. In fact, there has been some mention in ancient literature about, we all may have heard, the senior ones of us must have heard about a term which is called hysteria, which was very loosely used for many situations, like young girls with severe pain or sometimes undetected reasons, and anybody who would not behave in the right manner or you would not be able to diagnose what a problem is. It was common to name her condition as hysteria. And now there is enough proof and enough literature and enough studies has been done and compared past with these symptoms, and people have come up with the idea that it is possible that women who had been named as suffering from hysteria were possibly undiagnosed peritoneal or pelvic endometriosis. So there is no doubt that in human history, centuries and centuries, women have been subjected to, misdiagnosis because of, and very often subjected to psychological pressure and psychological diagnosis, and those may be suffering from endometriosis. So there's no doubt that endometriosis is a challenge of our times. It is one of the most damaging disease to affect the female pelvis. Reports show that all aspects of human reproduction, female reproduction, is affected, and it is like the danger within. The woman is not aware at all that she may be harboring a disease that is likely going to impair her fertility and going to cause her so much pain and discomfort in her reproductive age. We know that there are many biological mechanisms by which infertility can be caused due to endometriosis. Tubo-ovarian dysfunction is one of the most important aspect. The fact that there is anatomical distortion of ovary and tube in relation to each other, which is the tubo-ovarian relationship, and a failure of ovulation also sometimes, and various other mechanisms like abnormal peritoneal environment, dysregulated endometrial function, immunological disorder, possibly in anti-endometrial antibodies, and now a lot of research is being done on possible progesterone resistance, abnormal gene expression profiling in the endometrium. The point is that it can cause infertility by various ways, whether it is very mild minimal endometriosis or it is severe endometriosis. It can cause various mechanisms by which it can cause endometriosis. But what we consider when we are talking about surgery and other aspects is one of the most important, which is the anatomical distortion of tubo-ovarian dysfunction. So the role of surgery in endometriosis associated infertility, there is so much debate amongst reproductive endocrinologists and reproductive surgeons. If you will talk to majority of reproductive medicine practitioners, IVF specialists, they would say that there is no role of surgery anymore, and the fact that people are moving away from surgery where endometriosis is concerned. That, and reproductive surgeons would definitely swear by the fact that if the surgery is done by the right surgeon, done perfectly, properly, definitely it is capable of improving the fertility and fecundity of the woman concerned. So laparoscopy is the, we know that laparoscopy is the gold standard for diagnosis of endometriosis, and it certainly permits some amount of treatment and improving fertility. But there is so much discussion and so much debate about that. So the point is, because endometriosis related infertility raises complex questions for which there are no straight answers. Today I will be showing you a couple of videos and couple of cases. All of them are my own patients, my own cases. I have done the surgeries are all by myself. You may not all agree with my method of treatment or whatever I have done, but I would show them nevertheless. That is the point, because it's complex and there is no straight answer. There is no straight answer. You have to go and deal with each patient as to patient basis and decide what you feel is the best possible outcome, is going to give the best possible outcome to your patient. So now, having said that, I just could not help but show you one video. This is a recent video of mine, a woman who came with early pregnancy. There is a nice early intrauterine pregnancy. She came for an antenatal checkup, first checkup, and incidentally we found a huge 12 to 13 centimeter endometrioma on one side. So you do see these kind of cases also, where had she presented to us with a huge endometrioma, we would never have thought that she will be able to get pregnant on her own. So yeah, so this category of patients are also there. Now, for the sake of treatment and prognosis, in today's discussion, I would like to categorize endometriosis into these 5 categories. One is the stage 1 and stage 2, which is minimal, mild, moderate. Stage 3 and stage 4 endometriosis, which is more deep and severe endometriosis. The third is deep infiltrating endometriosis. Fourth is endometriomas of various categories. And fifth is recurrent endometriomas, or women with previously already operated for endometriosis. So these are the categories of patients that we should be discussing. In fact, whenever we see a patient in front of us, we should categorize them broadly in this manner. There are many various definitions and grades and categories. We have the ASRM grading, and many other extensive AHGL grading is there. We have very nice apps that you can download an app in your phone, and whenever you're doing a laparoscopy for endometriosis, you can put all the findings. It will give you very nice printout with the grade and stage and severity of endometriosis. There is endometriosis fertility index. So there are various ways, but for all practical points, these are the 5 categories in which we can categorize our patients. And the recent whatever guidelines I have taken today are from the very recent Israel endometriosis guidelines, which I think already the second speaker or third speaker is going to talk about today. So according to these guidelines also, the one PICO question which was asked in endometriosis: is surgery effective to increase chances of natural conception? This was one of the important questions that was asked. And yes, the answer for each stage was yes, whether it is laparoscopy for stage 1 or stage 2, or whether it is operative laparoscopy for endometrioma associated infertility, the surgery can improve patients' chances of getting spontaneously pregnant. There is currently no absolute guideline on deep infiltrating endometriosis. So just let us start discussing one or two cases, a couple of cases. This is a case of stage 1, stage 2 endometriosis, which is mild, minimal, mild endometriosis. Now, the challenge number 1 here is how to diagnose. And therein comes the role of a good transvaginal sonography. We know that very often the gynecologists, those who depend on radiologists to give their reports, very often minimal, mild, and subtle features of endometriosis will be missed. So a role of good endometriosis is very important. And so if preoperatively, laparoscopy, if you have diagnosed minimal, mild, then it is easy, because you will always plan how you will do a complete clearance surgery during laparoscopy. And therefore, also one has to see whether one has the capability and expertise to do a complete clearance surgery because that is what is recommended. It may not always be necessary, because we can overcome that by assisted reproductive techniques like IUI. However, but definitely improving the entire pelvic clearing as much as visible and active endometriotic lesions, that is very necessary. And if you diagnose during diagnostic laparoscopy by chance minimal mild endometriosis also, one should have the capability of doing complete clearance as much as possible, whether it is by dissection or it is by cutting and coagulation, however one may plan to do, or by laser, one must clear visible endometriotic implants as much as possible. So point here is that there is hardly any role of diagnostic hysterolaparoscopy anymore, unless there is any morbidity that you find in vaginal ultrasound. And a good vaginal ultrasound will give you features of subtle endometriosis, which if you have diagnosed before taking up for laparoscopy would be much better for the patient's point of view. Here is another example of a patient. This is a 26-year-old primary infertility of 3 years. This is her first consultation. She has normal male factor. Here comes the importance of good transvaginal sonography. Now see, when you have done a transvaginal sonography, although she has a report from a radiologist that says it's normal, maybe an abdominal scan, but when you do a scan, you see that the pouch of Douglas is completely obliterated. The fundus of the uterine outline is also not clear. Both the ovaries, although absolutely normal with a normal corpus luteum, appear to be very close to the uterus, probably stuck to the uterus. The visceral sliding sign is negative. The peritoneal sliding sign is negative. So here now the question comes whether you will be doing a diagnostic laparoscopy or not. Yes, if you will plan a diagnostic laparoscopy, then you must be prepared. You must be prepared and you must have the expertise to be able to do laparoscopic clearance of visible endometriosis, clear coagulation or excision, restore anatomy and tubo-ovarian relationship as much as possible, minimize any further damage, and also at that time do a good assessment of the pelvis, whether tubal function, tubal patency, other things, and also do a detailed endometriosis fertility index, because that gives you a very good tool to prognosticate to your patients as to what her chances of getting spontaneously pregnant are in the near future, in the next 1, 2, or 3 years. So one should, there's a lot of expertise. There may be nothing very much obvious visible on ultrasound, but there is a very big role on how well the surgery can be performed for patient to be getting maximum benefit. And in a surgery like this, once you have done as much clearance as possible, one can go ahead and plan a IUI, COH IUI for this patient. Very good chances that she will get a good outcome, because her tubo-ovarian relationship is good. Next comes stage 3 and stage 4 disease with or without endometrioma. Again, I'm showing you some examples. Now see here, this is a patient of 27-year-old. She is married for 2 years. She has come to you for pre-pregnancy counseling. She has not come for infertility. Primary complaint is dysmenorrhea, although now she is coming for pre-pregnancy counseling. You do investigate or not? Yes, you will investigate. She's 27, she's married for 2 years. Some investigation minimum you will do. When you do an ultrasound, you find a very small endometrioma, maybe around 2 centimeter or 2.5 centimeter. Now, no, you do, the minute you see a endometriosis, you will definitely want to do a AMH. At least I do, so it is 2.3. And her HSG is absolutely normal. The point is whether or not you will do a laparoscopy and operate on this endometrioma. Now, again, if in multiple national forums, we've had a lot of discussion and lot of debate and not lot of disagreement. But I did take her up for surgery. And when you have shown you this patient, how on earth can she get pregnant? There is no pouch of Douglas. The tubo-ovarian relationship is totally distorted. She cannot get pregnant with IUI at all. The ovary is completely buried in the lateral pelvic wall. It's also very difficult to take out the endometrioma. So if this kind of a patient, if only based on ultrasound, we do not do a laparoscopy, we will either we take her up for IVF, then there is fine, no need to operate. But if you plan to do a IUI based on HSG findings, etc., then there is no point, because her pelvis is simply not okay for an IUI. Now, here's another patient. 28 years old, she is primary infertility of 2 years. Her first line investigations show this following ultrasound. They show that she has a small 2 or 3 centimeter endometrioma in the left ovary. AMH is 2.1. Male factor is absolutely normal. Again, HSG is normal. Because you are a referral center, patients will come to you with reference. Now, she has, based on this finding, will you operate on her or not? Again, lot of debate, but I did operate on her because the fact remains that when you do a detailed transvaginal scan, you see that both the ovaries are stuck to each other. Both of them are on one side of the pelvis. The uterus is shifted to one side. So that makes me understand that there has to be tubo-ovarian distortion. There has to be enough anatomical distortion for us to first find out whether she is capable, if her tubo-ovarian relationship and pelvis is good enough for either a spontaneous pregnancy or a IUI pregnancy. So when you take her up, you have to do the pelvic clearance as much as possible, restore tubo-ovarian anatomy, and then take her up. If it's fine, then you do a IUI. If it's not fine, then obviously you have to do this thing. Now, this is another patient. She is 31 years old, primary infertility of only 1 year. And AMH is 0.1, 0.8. She came to me with that report. So I decided to repeat the AMH. It came to 1.1. There is no male factor. Now, here will you be doing a surgery or not? Because she's quite a big size endometrioma, almost 3 or 4 centimeters. There are no clear-cut guidelines because the guidelines don't always deal with each and every patient. Each and every patient is different. The other ovary is small. One ovary has a big endometrioma, the other. Whether or not you will operate now, this is another very big question. Many people with this AMH will want to probably come and do plan IVF straight off, but whether the patient will agree for IVF or not, she's married for only 1 year and her AMH is, so there are complex questions and there are no straight answers. So I'm not giving the answer to this patient, although I did plan an IVF for this one. I did not operate on her. I did stimulate her based on the recent guidelines, and that is another story for another day. Now, this is another patient. She is primary infertility of 5 years. Her baseline investigations are all normal. She's only 30. She is AMH of 2.87 nanograms. She has come to you. She's been referred to you for IUI. Now, when we do a scan, we see that her typical question mark sign is there, retroverted fixed uterus. Pouch of Douglas is partly obliterated. And when you do a scan, detailed transvaginal scan, you notice that there is subtle features of pelvic endometriosis. And so I do take her up for IUI, for laparoscopy, because I tell her that if you are not a fit candidate for IUI, then what is the point in wasting time in IUI? And see, this is how her pelvis looks when you take her up for a diagnostic laparoscopy. Pouch of Douglas obliterated. There is both the ovaries are buried in the lateral pelvic wall, and there barely any tubo-ovarian relationship to speak of. You can see that there is severe uterosacral endometriosis has made the uterus, retroverted, fixed, and even pulled the bilateral adnexa deep into the pelvis. However, if you look at each ovary, they're normal. The tubes are absolutely open when you do a HSG. So, if we have to summarize as to who needs surgery in endometriosis-associated infertility, young age, good ovarian reserve, women with significant pain, and those who have very severe disease like very huge endometriomas and like visibly causing a problem. So there's no denying the fact that there is a role of surgery in endometriosis, but these are the best markers wherein you should consider. But having said that, one must also remember that the first surgery is the make or break surgery. I see such patients with bilateral huge endometriomas in young girls just married or even adolescent girls. And when there's no way but to operate on them. And there's no way that they're going to have a childbirth in the near future. They are like, this particular patient was barely 21, and you can see I have no time probably to go entire video, but you can see this is almost a 18 centimeters size endometrioma, bilateral with multiple endometriomas in each ovary. And so here comes the role of performing a good surgery. Skill of the surgeon is very important, and energy source, what you're using, pitocin infiltration, whether you'll use adhesion barrier or not, ovarian reconstruction, role of suturing the ovary and using adhesion barriers, all these things become very important, and this will become like a time taking and a very extensive surgery that she will be needing. And also here comes probably the role, if she is very young, like 20, and far from her planning her pregnancy, probably the role of ovarian tissue cryopreservation also comes in patients like this, where people have started getting aware of these things. Anyway, now, having said that, next question comes as to which patient should. It is very important that once you have done a surgery, and during surgery you have done a detailed endometriosis fertility index, they must be counseled regarding their chances of becoming pregnant after surgery. And this EFI will give you a very good prognostication. So if the patient is young, endometriosis fertility index is high, then you can plan for even leave them for a year or 6 months for natural pregnancy. And based on your assessment, you can plan IUI for them. If otherwise, you can plan IVF for them. But that prognostication and proper characterization is very much necessary. Next comes another very important question: is infertile women with grade 3 and grade 4 disease, with or without endometrioma, whether to operate or not to operate. That becomes the most important question when there is severe endometriosis. And my point here I'm trying to put in is that don't disregard the fact, let's not just say ki no, surgery is never needed and everybody needs IVF. That's also not correct. So the first question which we have to ask whenever we see a patient who is infertile and who has endometriosis of whatever stage, whatever grade, first question we have to ask, is she a patient who needs IVF? If she's not a patient who needs IVF, then you may consider, you must plan surgery, you must plan pelvic clearance, assessment of the fertility, and then plan IUI or natural conception. So who needs IVF? Those who have low ovarian reserve, those who have low endometriosis fertility index, whose tubal function is compromised, or there is complex factors like even male factor is there, other treatments have failed, etc., etc. And here comes the role of emergency IVF. There are situations with endometriosis, older patients, ultra low AMH, wherein she might be a case for emergency IVF, and then accordingly you have to counsel the patient. Accordingly, you have to counsel the patient. If the patient is for IVF, surgery is not recommended at any stage of endometriosis. Even with stage 1, stage 2, even with very small endometrioma, if you see, but you know that this patient needs IVF because she is older, her AMH is low, she has had multiple treatments, she has multiple factors, her husband male factor is also there, then surgery is the last choice. Now, having said that, I will show you another case. She is 32 years old. She's married for 6 years. Her AMH is 1.69, HSG patent tubes. She has normal male factor. On transvaginal sonography, you see at least 4, 5 small, big endometriomas on both ovaries. 1 centimeter, 1.5, 0.5 centimeters, 2 centimeters, like that. 5, 5 or 3, 3, 4, 4 on both sides. The uterus is normal. Now, obviously, the first question is she for IVF? Yes, she is for IVF. She's married for 6 years. She is 32. She has endometriosis. She has a AMH which is borderline. So she is for IVF. But if she is for IVF, will you do a surgery or not with these multiple bilateral endometriomas? Again, like I said, you all may not agree with what I did, but I did take her up for surgery. The plain reason, simple reason being, both sides she is studded with multiple endometriomas. How we will do the egg collection? It will be so difficult and it will be so bizarre, and that is why I took her up for endometriosis. I did my best to do a clean job, given pitocin. I will forward it. Almost no energy source at all. Cold scissors were used to clear the pelvis as much as possible. I wish I could run this. Five o'clock already. So let me go through quickly. Both the sides ureters are being dissected. See, even as many, almost 3, 4 cyst walls I removed without any energy source. Pitracin was given, and I did a clean job as much as possible to the best of my capability. See, multiple endometrioma cyst walls being removed in an absolutely clean manner, not much bleeding, and no energy source used at all. And after doing that, I took her up for surgery. Again, this is open to debate. I don't think I have much time. Another important question is if you have hydrosalpinges and those who are for endometriosis. And those who are for IVF. Obviously, I am sure that you will have to take her up for surgery, do the bilateral clipping. And if there is such a big endometrioma, you will definitely drain it. And based on its location and capability and time, you will decide whether a cystectomy or not. So which endometriomas must be treated or operated even before ART? Even if she's for IVF, you have to operate. Rapid growth of endometrioma, sonographic suspicion of malignancy, because 9% repeat endometriomas harbor malignancy, severe incapacitating pain, risk of rupture of endometrioma, or if you suspect that the endometrioma is ruptured, which also we see once in a while, patient comes in acute abdomen, presence of hydrosalpinges, large size oma, there is no guideline, and the recent guidelines also I'm not very clear whether you must operate on something endometrioma which is 4 centimeters or more, and if it interferes with OPU, and repeat endometrioma surgery almost never. So to end, my 10 key takeaway points where endometriosis and surgery is concerned. Surgery certainly has a place in endometriosis-associated infertility. The best indications are a young patient with good ovarian reserve, no other causes for infertility, no history of previous pelvic surgery. Please remember that the first surgery is the make or break surgery, and for the sake of the patient, we hope that the patient lands up in the correct hands. Surgery to improve chances of natural conception and to establish endometriosis fertility index. That is what we have to stress on the patient, that this is the reason why also you need surgery. 1 year post-surgery is the best window for pregnancy, COH, IUI following minimal mild endometriosis, no role of ovarian suppression before or after surgery. Surgery also has to be done for symptoms, very large endometriomas or hydrosalpinges. No surgery prior to assisted conception, and repeats at surgery almost never. Thank you so much. I hope it was useful. You know, one has now lost touch with webinars. One wants only physical meetings these days. So I hope it was useful.
Very
Yeah.
Vidya ma'am, comments, ma'am? And
Yes.
Panda
Yeah, yeah.
sir?
It
Yeah.
was really Dr. Panda was there. Huh? Dr. Jitendra
Dr.
Panda, you want to comment? Yeah, please
Dr.
comment
Panda,
on
you have
that.
to unmute. Unmute, sir. Sir, you have
Unmute yourself.
Yeah.
Yeah. Am I unmuted now?
Yes, sir.
Yeah.
Can you hear me?
Yes.
Can you
Yes,
hear
sir.
me?
Yes, sir.
Yes, sir.
Am I audible?
Yes,
Yeah.
sir.
Yes, sir.
It's good to
Yes.
see the smile on Dr. Sujata Kaur's face, because she is our city girl. I belong to the same city as Bhubaneswar. And
Thank
fortunately, I am sitting in the chair here by the grace of Dr. Manika Singh and Manisha Join. And thank you very much, madam, for giving me a chance to chair this session here. Dr. Sujata Kaur's CB was very much explained earlier, but she's the first girl in our city to start ART, and she's a very good laparoscopist. So is no doubt she can judge her patient judiciously which way to go, whether to do laparoscopy to improve the fertility, or to go ahead with IVF straight away, because she's a master of both the things. Well, Dr. Sujata, I was very fascinated to see your topic, the name you gave, endometriosis surgery for infertility, different strokes for different folks. That topic is enigmatic. The subject, the nomenclature is enigmatic. The endometriosis is enigmatic, never ending. We have been learning it for so many years. Is not and is really very fascinating. That means you patients to use in
Thank you,
your
sir.
treatment to different patients, depending on say stage 1, 2, or stage 3, 4, or you mean perhaps different folks like us, different doctors, different gynecologists, a different choice for the different disease of endometriosis, different level of it. So it means in either way. So you have kept this topic enigmatic and give us a chance to think ourselves in our way. Anyway, you dealt it so well, so nicely, such a difficult topic. But I personally believe that to improve the infertility, yes, if it is stage 1 and 2, you do the things and go ahead. To do heroic surgery in advanced endometriosis like DIE and doing the pelvic frozen pelvis and you clear it, why should we put our patient to that situation when in your hand IVF results are so good? Anyway, you are the best person. You judiciously choose your patients. And well, I have nothing more to add other than saying that your deliberation was very interesting and very informative. And we really enjoyed it. I look forward to hearing it again. Thank you.
Thank you.
Thank you, Panda sir, for accepting our invitation. Because first, when I talked to Dr. Panda, he was not very keen. But then through my persuasion, and I think I managed to convince her that he would be the best person for Dr. Sujata. Thank you, sir. Thank you, sir.
Thank you, Sujata. It was an excellent presentation. And many times we always say that the first surgery is the best surgery, as you told. But many times the endometriosis is minimal. We operate also, but the outcome is not good. So many times it is unpredictable. So even though so many guidelines, ISHRE guidelines like changing, instead of that, the surgeon is in dilemma always. The treatment of this enigmatic disease is always full of dilemmas. So thank you very much. And thank you again, Dr. Pratibha, Monica, Manisha, Dr. Anita, and our Shabana.
Thank you.
And those who have joined. Really, it is very good. In endometriosis, whole March, I'm listening to endometriosis various webinar. This is the best one. Thank you.
Thank you.
President of
Thank you.
Obstetrics Gynae Society, Dr. Anita Srivastava has joined us. Dr. Anita, would you like to address us, please? You
have to
are
unmute yourself.
you're muted, Didi.
Congratulations, Monica.
Thank
You
you.
did a very nice job. Dr. Sujata presented her topic in a very elaborate way and in a very nice way. It was a very nice talk, and you are doing a very good thing for promoting each and every topic in a detail for everybody. I congratulate you and all the best for further series.
Thank you. Thank you so much.
Thank you.
Thank you. Thank you.
Dr. Manisha, our international speaker, has
Yeah,
also
yeah, he has joined. So if he wants to take the session, he can take. I
Right.
can talk later. You just
Yeah.
ask him.
Professor Zeng, would you like to proceed with your talk, please? Or
Yes.
the Professor Zeng, would you like to start your talk now?
Okay.
Or would you like to wait?
Share screen.
Sir, can I just take 2 minutes and introduce your chairs?
Sure.
Thank you.
Okay.
Thank you so much. Dr. Manisha, please proceed with the session.
Thank you,
Pratibha
Sujata.
ma'am, with your permission?
Yes.
Yes,
Thank you. Thank you, ma'am.
After the wonderful talk by Dr. Sujata, madam, we move on to the next session with the international speaker, Professor Zain. And to chair his session, actually, we have Dr. Shabana Sultan, madam, and Dr. Riganka Molly, sir, with us today. Dr. Priyanku Raya, sir, I think they are late to join. So, okay.
The session 2 chairpersons can chair.
Yeah, they can chair. Yes.
Can chair. Manisha, please.
Dr. Mriganka Molly, sir, he is the president of Kalyani Obscani Society and currently the assistant professor. And he's been the co-chair of Clinical Research and Good Practice Committee, CEFOC, and also received the Foxy Kamini Auditor Award in East Zone, has been the winner of various other awards and the national and international faculty tours. Welcome, Dr. Mriganka. Next.
Thank you. Thank you.
Yes, sir. Dr. Shabana Sultan was already been introduced earlier. She is a very active and dynamic member of the Collaborative Society, currently the head of the department and secretary of society. Very active member. Over to chairperson without wasting much time. Thank you so much.
Very good afternoon. It is a very nice series, and we are today having none other than Professor Chi Rui Jing, and his specialty in IVF and ART, hysteroscopy and fertility preservation, endometrioma, advanced aged caused infertility, primary ovarian insufficiency, pre-implantation genetic testing, and pre-implantation genetic diagnosis. Currently, he is the founder and CEO, Taipei Fertility Center, Honorary Professor, Taipei Medical University, Secretary General, Asia Pacific Initiative on Reproduction as per Founding President, Taiwan Endometriosis Society, Board Member, World Endometriosis Society, International Society, Fertility Preservation, Pacific Rim Society for Fertility and Sterility, Asian Society for Fertility Preservation, Asian Society of Mitochondrial Research and Medicine, Taiwan Society for Stem Cell Research, Taiwan Society for Reproductive Medicine, and Sir has also awarded in year 2010, 14, 15, 17, 18, 21 Star Award, American Society of Reproductive Medicine. We all know ASRM. 2016 Research Grant Award, Taipei Medical University. 2012 Lifetime Achievement Award, Global Chinese Association for Reproductive Medicine. 2001, 2003, 7 Prize Poster, European Society of Human Reproduction and Biology, Israel. So, sir, the dais is yours. Welcome, sir.
Thank you very much. Very kind introduction. First, I would like to express my sincere appreciation to Sujita and Sujata and the colleagues for inviting me to join this Foxy very important meeting. Today, I will touch upon the biomarkers of the endometriosis, which may be cause infertility and their importance. So may I share the screen? Okay.
Yes.
Where is the mask? Share screen. Share screen.
There's a button at the bottom, Professor. Share screen is a green button at the bottom.
Yeah, this one. Is that?
Yeah, we can see your slides.
We can see it? Okay.
Yes.
Yeah. So thank you very much again for this Foxy webinar series. As you know, the prevalence of the endometriosis is very common. As you can see this slide, in my hospital, 50% during the laparoscopic diagnosis, you can due to endometriosis. Also very similar in Korea, Norway, and some European countries. So in average, 50% during laparoscopic, you can find out the disease of the endometriosis. And 100 years ago, Professor William Osler from Johns Hopkins already mentioned he knows endometriosis, knows gynecology. The pathological mechanism of the disease is very obvious. As you can see, the endometriosis can increase the response of oxidative stress. Also, the create cell cycle dysregulation, impair steroids metabolism and biosynthesis, and of course, the inflammatory environment and impair angiogenesis also occur in patients with endometriosis. As the consequence, you can see they will deteriorate the ovarian reserve, worse the control ovarian stimulation outcome, low oocyte quality, as well as impaired embryo quality, and finally, implantation also are impaired. So today, my topic will cover the pathogenesis and RS, oxidative stress in this disease. The pathogenesis of the endometriosis, as you can see, they are very, the implant of endometriosis will cause the invasion, stemless fibrosis and angiogenesis by increase the MMP production and also TGF-beta increment, and also some of cytokine as well as VEGF. And this cytokine also occur in the endometrioma inside the ovary. As you can see, this TGF-beta reactive oxygen species will increase the fibrosis, decrease the vascularity in the ovary. So as a result, you can see the atresia of the early stage follicles, and also the downregulated aromatase in activity, as well as E2 production. Most important, in the ectopic endometrium, you can see decrease the progesterone and also decrease the LIF, which is very important implantation markers. And also you can find out the integrin alpha beta 3 decline, which will impair the implantation. And at the same time, because the inflammatory cytokine also and the decreased progesterone production, the desensitization of the stroma also impaired. And how do the early diagnosis of this disease? Very often, when you do laparoscopic diagnosis, you see the spots of the endometriosis, the lesion, okay? And at the same time, very often you see accumulation of the bloody or serosanguinous peritoneal fluid in the cul-de-sac or Douglas pouch. And very often, during the ultrasonographic examination, you can see these 4 different patients. As you can see in the cul-de-sac, you see a lot of bloody peritoneal fluid accumulation here, and also in the third patient and the fourth patient. And this bloody PF, they contain abundant ion concentration, especially in those patients with endometriosis. So you can see this is a stage dependent. As you can see, this control is stage 1 and 2 and the advanced stage. As you can see, this ion concentration is much higher in PF of advanced stage compared with control. However, you can see the serum concentration, almost no difference. You can see this serum. And what's the impact? What is the impact of this ion concentration? As you can see here, because the ion, they can induce so-called Phantom reaction. So you can see the ferrous ion, they can turn out to be a ferric ion. At the same time, they can convert hydrogen peroxide to the very toxic hydroxy radical. So all these 3 OS are very detrimental to our oocyte embryos. And as a result, they are leading to the lipid oxidation. That means our cell membrane usually contain a lot of polyunsaturated fatty acid will be opened by this RS and end up with protein damage DNA damage and then embryo injury. So we do some studies. You can see the markers of the DNA damage, i.e. 8-hydroxy deguanosine. So when we use the HPLC to determine these markers of DNA damage, you can see tremendous increase in those patients of chocolate cyst compared with the control is in the blood or normal endometrium. So you see 8-hydroxy deguanosine much increase. And also you can see the adenomouse is also increased, and that is significant. So this evidence of the DNA damage. And the other markers is lipid peroxide, which is MDA. You can see here, 2 molecular DNA combined together, that is end product of this lipid peroxide. Again, you can see here this for those patients with chocolate cyst and adenomyosis, these lipid peroxide are also much higher compared with the control. And what is the impacts of the disease on oocyte and embryo quality during ART treatment? As you can see, the endometriosis will very influence on the human oocyte morphology. When you look at all the parameters, as you can see, this is control group, this endometriosis. As you can see here, the fragmentation of polar body 1 is quite higher in patients with endo. The other thing is you can identify the perivitrinized material, also increase, and abnormal oocyte shape, as well as intracytoplasmic vascularization, much obvious, evident in patients with endometriosis, especially their oocyte morphology. The other abnormal finding is mitochondrial structure and function. As you can see here in oocyte of endometriosis, you can see the mitochondrial abnormal ultrastructure. You can see here increase, okay, in endo compared with control. So you see very bizarre shape of the oocyte mitochondrial ultrastructure compared with the very elongated normal one. And the second one, you see the decline of the mitochondrial number. You see the decline in patients with endometriosis. So you can see very scanty mitochondrial number and compare with control. The most important is also decreased mitochondrial DNA copy numbers. As you can see here, in control, much higher in mitochondrial DNA copy number compared with the disease, and that is a significant decline. Then we look at our data from our IP laboratory. You can see here the morphokinetics. We use the time-lapse and clinical data and look at all ovarian endometriosis after propensity score matching. As you can see, also we have 2 arms. You can see the time to morula stage and the time to blastocyst formation about 2 to 3 hours delay. So you can see this is control group, 86 hours, but here's 89, about 3 hours delay. And also blastocyst formation, also about 3 hours delay. But most striking data is the initial rise of the serum beta HCG. If the patient conceive, you can see the ovarian endometriosis group is almost delayed, about 600, compared with 1,500 IU in non-endometriosis control. And also that is significant different. And also our data are very consistent with other publications. You can see time to blast molecular formation, time to blastocyst formation, also about 2 hours delay. And also we discover in those patients with endometriosis, when we look at examine their granulosa cell, it's a tremendous fragmentation in the mitochondria of human granulosa cells in disease. compared with the control. See, we use the male factor. You can see the beautiful elongated mitochondria compared with fragmentation. And this finding also you can discover in patients with PCOS, especially in their granulosa cells. So that means a patient with endo and PCOS, usually they are under extreme oxidative stress compared with other indication. And then we look at the antioxidant enzymes such as glutathione peroxidase in granulosa cells of the disease. You can see the glutathione peroxidase extremely depressed. You see, depressed in endo and PCOS compared with the control. And what is the impact of this endometriosis? Because endometriosis can secrete and secrete the TNF alpha and a reactive oxygen species. So this will decrease the ER stress, cell cycle dysregulation, and end up with autophagy. So that is not good for our gametes. The other thing, the secretion of the cytokine, especially TNF alpha, they can decrease the telomerase activity, and finally DNA damage. So you can identify the mitochondrial membrane potential also decline, ATP decline. So as a result, you see the apoptosis, steroidogenesis decline, and they will impair the whole granulosa cell activities. And the biomarkers in diagnosis of the disease is such like here. We use the immunolocalization such as CD34. And the CD34, this is a biomarker of angiogenesis. So you can see here, you can see something like a small vessel formation. Okay, and this is control group in the tissue of the chocolate cystic wall. However, following the treatment of GnRH analog, you can see all the CD34, the markers of angiogenesis disappear. The other marker is vascular cell adhesion molecule 1, and in patients with endometriosis before and after GnRH treatment. As you can see, this is control. Especially you see the line epithelium of the chocolate cyst with heavy stain of the vascular cell adhesion molecule 1. However, following the GnRH treatment, almost gone. You no more disappear. The other markers use immunohistochemistry staining, cat healing in human chocolate cyst. You see all the line epithelium, small, this is magnification. We also see heavy stain with cat healing. And this is why this disease can have some adhesion formation properties, characteristics. The other biomarker is OPN, which is osteopontin. They can induce endometrial cell migration, invasion. You can see the scratch mesothelial migration characteristics. Also then activate MMP formation. And also you can see the acting remodeling. As you can see, when we overexpression of OPN, you can see the acting formation. However, when ate or supplement with alpha V beta 3 inhibitor or OPN inhibitor, you see decline of this actin formation. The other biomarkers we discover is alpha-1 antitrypsin, A1AT. A1AT, this is a small molecules, not big, about 52 kilodalton. And this marker, the sensitivity and the specificity is much, much better than CA125. See, only 18%. Here, sensitivity is 74%, and 90% of specificity and 19% of CA125. So we use the proteomic approach. As you can see here, we can identify these markers, about 52 kilodalton. And this marker can be downregulated when patients receive the GnRHA treatment. So you can see each patient, the marker A1AT decline. Right. And this marker is very, very important because we can identify the early disease. You can see this is normal control. And when it's early disease, stage 1 and 2, it already goes up. No mention how the advanced disease. And the area under the curve, AUC is very high, 0.974. So I think they're very specific markers. And then we use the immunohistochemistry localization. On the left-hand side is alpha-1 antitrypsin. You can see heavily stained with the brown color. However, treatment with the GnRHA almost disappear. No more. You can see the markers, A1AT. The other most important marker is tension 1. And the tension 1 is a very important markers because they link the cytoskeleton to the extracellular matrix by linking to the beta integrin. So you can see this tension 1 acting from cytoskeleton and the ECM by linking this beta integrin and acting. And this marker is responsible the endometrial cell migration and invasion. So it's an important component linked to the ECM and acting cytoskeleton, responsible for the cell migration. So that's very bad. This is why there is some migration or invasion characteristics. However, following the treatment, the GnRHA also decline of these markers. And in patients with the disease, always the patient complain pain, right? Pain dysmenorrhea. And we find out very important marker is neuropilin 1 and neuropilin 1. As you can see here in the endometrium in proliferative phase, you can see neuropilin 1 is highly expressed. You can see the line epithelium with brown color compared with control. However, after ovulation in the secretory endometrium, you never see it again. It's gone. So maybe progesterone has some, maybe the neuropilin is associated with estrogen, and when progesterone goes up, it disappears. And then we look at the disease. Okay, this is endometriosis, and this is with treatment and without treatment. And you can see endometriosis without GnRHA is highly stained, both in the gland and the stroma of the neuropilin 1. So this is why the patient always complain pain, because it is related neuroblast formation. And however, following the GnRHA treatment, you can see the neuropilin almost gone, no more. You can find out in the tissue. And as you all know, the endometriosis is estrogen-dependent disease, and estrogen is a kind of growth factor. They can inhibit BAX and activate BCL2. So the inhibition BAX and the cascade cytochrome C, cascade 3 almost block. So the disease cannot be shrink because of activation of BCL2. And at the same time, the estrogen also induce the production of PS3, KAKT, and mTOR formation. And this mTOR also allow and induce proliferation of the endometriotic tissue. So it's getting bigger, and larger. Okay, so that is the estrogen is very important factor. They block apoptosis and also induce proliferation. However, when patients receive GnRHA, okay, they block the estrogen, very low level serum estrogen, and then there will induction of the BAX formation, and the cascade will be apoptosis of the tissue. So you can see the size of endometriosis or size of endometrioma shrink smaller, and at the same time, they will block this mTOR pathway, and this blockage will allow another functional LC32 and bacterin 1 formation to proceed or induce the autophagy pathway. So by induction of lysosome to this autophagal lysosome, they digest all the endometrial tissue. So again, this mechanism, apoptosis and autophagy, they induce, they will cause the shrinkage of the disease, make it smaller. That is, and the association studies trace matter, you can see the, this is an association study, you can see this is two arms, this is endometriosis patient, this control patient. You can see the tertile ratio of the zinc in the blood also very high in non-diseased, in control group. So we maybe we conclude maybe the zinc is some protective effect to prevent.
I think everyone, 1 second, sir. Everyone, please mute your speaker and listen to the speaker. Okay. Everyone in the seminar, please mute yourself.
So you
Sir,
can
please.
see the zinc. The zinc, some protective effect, and the last ratio also shows some protective effect of the zinc. The other heavy metals, the heavy metals is lead, Pb. Pb, when you see in the tertile fashion, you can see in the disease with endometrial disease group is very high, 38% versus control of 29%, and that is our odds ratio is about 2.2. So this is a detrimental effect of some association. When your serum lead level is too high, you maybe have some possibility to develop the endometriosis. And we look at this one because
Please,
What is
I think
everyone,
organizer,
please mute.
mute. Somebody is speaking.
Support team, please mute other people.
Otherwise, we cannot continue. Please mute. Sir is telling, so everyone, please listen and mute yourself. The host, who is the operator, please mute everyone.
Support
Except
team,
for
please
sir.
mute.
you can see this decline, this is GST gene polymorphism is a risk factors for those patients with endometriosis. And this GST gene polymorphism, this gene, okay, GST-M1 and the GST-T2, this is a detoxification directed gene in endometriosis, especially they can remove lead, okay, lead so as you can see, we check all the patient. This is patient, this is control. If the patient with very high level of serum lead, usually see there are no existing of this polymorphism because they're very important detoxification enzyme are gone. So this is why they are very easy to harbor the disease compared with the control. So for example, it's a very high lead level, 60% without these polymorphism genes, both M1 and M2. See this 60%, but in the control, only 40% without this gene. The other one also same, 60% without this gene, but in the control, healthy one, only 47%. So this gene is very important. The other, I think, is the EDC, endocrine disrupting chemicals started. You can see this is a diester started, monoester. After hydroxylation or oxidation, finally they can remove in the liver by gluconization. Okay, but the bad thing is there are many metabolites of DHP, MHP, and then many metabolites in urine. And as you can see, we also do the further studies. We have two arms. One is disease endometriosis, one is control, and we measure their metabolite of this EDC, and this is 5 major metabolites. And again, we are very interested to find out in disease, this and the control, And these 5 major metabolite of phthalate, okay, metabolite, especially in the methyl-butyl phthalate, you can see is almost, the odds ratio is 1.4, almost 1.4. That means 50% increase. So you can see in endometriosis, the MVP is 148, it's only 109. And that is significant. So the association of phthalate metabolite also very important. And this phthalate metabolite is very easy to find out, especially this one, this DBP, they can turn up a metabolite to MVP, okay, MVP. And this DBP is a commonly used plasticizer, commonly present in butter, infant formula, cosmetics, nail polish, lotion, and perfume. Very scary, right? So every day we exposure in those EDCs. And this monobutyl phthalate, especially affect our granulosa cells. As you can see, in low dose, maybe no effect. They can continue to produce progesterone. However, high dose methyl-butyl phthalate, they will impair the G2/M2 phase of mitosis and the spindle assembly checkpoint. You see, all these genes are downregulated. And other things, the ovarian stimulation also impaired. You can see down-regulate AMH, inhibin B, steroidogenesis decline, and cytokine increase. So as a result, the ratio of mitochondrial membrane potential also decline. And the phthalate also can induce the impact on the endometriotic cells. As you can see, 5 major adverse effects: inflammation, invasion, oxidative stress, cytokine production. So those adverse effects, finally, they will increase cell viability. So they never die. The endometrial tissue never die, and the resistance to hydrogen peroxide, okay, because all the enzyme, antioxidant enzyme decrease, so resistant peroxide and proliferation. So that is the bad things, because the phthalate, the relationship to endometriosis. So finally, in conclude, the oxidative stress in endometriosis triggered by free ion in PF leads to both oocyte and embryo DNA damage and lipid oxidation. And endometriosis impacts on oocyte quality by decreasing mitochondrial number and mitochondrial DNA copy numbers, and change oocyte morphology and embryo morphokinetics. And the biomarkers of inflammation, angiogenesis, MMP activation, anti-apoptosis, and adhesion formation are also very activated by E2 production and can abolish by GnRH treatment, pretreatment. And the association studies shows the PB and the decline, the GST gene polymorphism are risk factors of endometriosis, whereas zinc has some protective effect. And the urinary phthalate metabolites acts as NEDC, may increase the risk of endometriosis. And finally, this is my purpose, because the putative biomarkers in endometriosis, as you can see, it's very hard to diagnose it, the early stage of endometriosis, especially stage 1 and 2, unless we do laparoscopy. But nobody patient had to do laparoscopy just for diagnosis. So I collect in the last 20 years in my laboratory, we end up with this one, all the markers: apoptosis, autophagy, adhesion formation, angiogenesis, cell proliferation, hormone receptor, migration, growth factor, etc. And there are 2 kinds of markers. One is serum markers, one is tissue markers. If we are going to do the early diagnosis, only serum markers work, not tissue. So you can see the brown, the square marker, square. You can, so these markers, serum markers, I just point out, is helpful and very possible some feasibility for early diagnosis. If we convert to a chip, okay, and all these information, serum markers, growth factors, we can use in the future. So this is my final goal, the final goal, endo chip. We put all these markers and we use the ELISA method, okay? Just we do the pregnant test ELISA method and put all this marker here, and probably patient only pay about $10 or $20. I can early diagnose this disease in advance. So that's my final goal. So thank you very much for your attention.
Thank you, Professor Zhang, sir. It was a very nice, elaborative, and beautiful slides were there, sir, for explaining the pathogenesis of endometriosis, for explaining all the biomarkers like CD34, VCAM1, immunochemistry by E. Catherine. All these biomarkers you have explained very nicely, and you have explained various studies coding so many datas in which were explaining like association of endometriotic patient with the various stress metals as well. So I think very nicely elaborated. Thank you so much. Greetings from India. Greeting from city of Bhopal.
Yeah.
Thank you. Thank you, so for your invitation. I'm very happy to join you this
Professor,
webinar
it was
series.
nice to see you after ISAR and after Aspire. Hi.
Thank you, Professor Zhang. That was a very, very, a mind-opening talk for all of us, because biomolecules and biomarkers is the future, how we can control this enigmatic disease.
Yeah, because, the disease always delay diagnosis for 7 years in average. And unless we do, very invasive laparoscopic method, but it is impossible for every patient. So if we can develop a serum markers, I think it's very helpful for early diagnosis and early treatment until it's too late.
Yeah.
And the other one I just mentioned, probably use the ultrasound. You can see the accumulation of the bloody cul-de-sac fluid. That's a very early sign. So that is very cheap method. You do ultrasound, you look at the cul-de-sac, and you see the accumulation. And also, if the patient complains the 4D, dysmenorrhea, diarrhea, dyschezia, and with this ultrasonographic finding, maybe you may warn your patient, you are high risk of endometriosis.
So, Professor, like in all minimal and mild cases of endometriosis also, we'll be able to appreciate fluid in the cul-de-sac?
Yes, usually. And the worst one is the bloody fluid contain ion. Ion, they can turn out a generation abandoned ROS. That is bad things. They will damage our embryo, oocyte, etc.
Excellent talk, Dr. Zhang. And I just want to ask you that will be doing all biomarkers in all the cases of endometriosis or some selected cases? Like,
and we can
how
do
do
it.
you go about?
Yeah.
Because India, we are not that much well-versed with biomarkers. So serum biomarkers should be done in all the cases, or it should be just kept for research purposes, or for the very early, very late cases of endometriosis.
That is the future. Use the biomarkers. The future. We see. You see with pregnancy test, right? The urine test. That is the EIA method. Every day we do pregnancy test by urine. We can develop this, but there are some overlapping of some bios. So you put not just one marker, put about 7 or 10 markers together. So you can have some bias, because some, especially interleukin 1 or interleukin 28, they are not only present in patient with endometriosis. So let's put R1 beta, put in A1, AT, and some other put together. So your bias will diminish, accuracy will increase.
Okay, excellent. Thank you so much for joining with us and sparing your valuable time and valuable information.
Sujata is there.
Thank you so much.
Sujata Carr, Dr.
Sujata.
Yeah, I'm there.
Yeah, okay. Say hello to you.
It is a nice talk.
Thank you.
Sir, it is
It's
a
nice to
nice
see you
talk.
after ISAR and Aspire.
Yes.
It's a
Hope
nice
you're doing
talk.
well.
Just one question. Whether
Yes.
any ideal marker, biomarker, which do you think? Any biomarker you prefer?
We should put not just single one markers. See, we put together markers. Some, no. Several markers put together.
Yes.
To avoid the bias.
Yes.
You know, just this is ideal. Not maybe so more put together. I say ELISA method. So you can a drop of serum or urine and put it in, and you're positive, and then you say, oh, you're high risk of endometriosis.
Yeah.
This is cheap 10 candidate genes put together. CD34, it can healing, right? Vascular therapy, molecule A1AT, put all together.
Thank you very much. Innovative ideas. Thank you, sir.
Thank you very much.
Thank you very much, sir.
Thank you, respected chairpersons and Sir Professor Zhang for a wonderful talk. We now move on to our next talk by none other than Dr. Pratibha Singh ma'am, who is the committee chair of IAC. And madam would be speaking on the recent guidelines of the ISHRE. I request all others to please mute themselves. Yeah, to chair the session, we have with us today Dr. Priyanku Roy, sir. Can I have Dr. Priyanku Roy, sir, CV? Sir is a well-known
Dr. Zhang,
national
Dr.
faculty.
Zhang, please
yes.
Stop screen sharing.
Stop sharing.
Thank you.
Thank you.
Yeah, Dr. Priyanku Roy, sir, is the chairperson Public Awareness Committee, POXI. A well-known figure of Indian this thing, and he's also contributing in variously in FIGO. He's president of WETOG. He's the member of Women in Crisis Committee, FIGO, member of Scientific Program Committee, FIGO World Congress, and now he's been the joint secretary.
Okay, ma'am.
Yeah.
No problem. It's fine. Thank you, ma'am.
Okay, so our next chairperson is, I think, is busy with some emergency. Dr. Chintan Thakkar is not able to join us, so I request Dr. Priyanku Roy to please take forward the session.
Thank you so much, ma'am.
Thank you.
It is my pleasure to invite our speaker today, Pratibha Singh ma'am, who's going to speak on the recent ISHRE guidelines on endometriosis. So Pratibha ma'am is a senior consultant, of course, practicing in Bhagalpur. She is currently the chairperson of the International Academic Exchange Committee and has done a lot of good work with the committee and otherwise as well. I consider her to be an elder sister. She is from the East Zone itself, from Bhagalpur, which is very near to Siliguri as well. And we have done a lot of conference trips together and otherwise as well. So it's a pleasure to have you, ma'am, and to chair your session. I welcome you to kindly share your thoughts on the topic. Thank you, ma'am.
Thank you, Dr. Priyanku. Can I share my screen? Can you see my screen?
Not yet, ma'am. Yeah, it's visible.
Is it full screen?
No, I'll have to put on the slideshow.
Oh, it's not slideshow. Now is it full screen?
Yes, ma'am.
Yeah. So, respected chairpersons and my dear friends, a very good evening to all of you. And thank you, Priyanku, for such wonderful introduction of mine. And first of all, I would like to thank our organizers, especially Symbiosis team, for giving me this opportunity and including me in this very prestigious webinar. And we just heard a very lucid and very informative talk by two of the stalwarts, Dr. Sujata Gar madam and our international speaker. Now I am here to talk on recent guidelines on endometriosis, and this is 2022 ISHRE endometriosis guidelines development group. Now, endometriosis as such is quite complex entity, and the controversy starts right from its etiology to diagnosis to management. So we must keep updating ourselves in different management and for the diagnosis of endometriosis. Now, what is endometriosis? It is chronic inflammatory disease with endometrium-like tissue outside the uterus, and endometriotic tissue is estrogen dependent, that all we know. And it is mostly found in the women of reproductive age, although the clinical consequences of endometriosis and its management can last up till menopause. So this is what I am talking today is the second update of ISHRE guidelines on endometriosis. Although there are still remain many unanswered questions for which it has been highlighted by making research recommendations and good practice points. For that, it was developed a basic on clinical expertise by the experts in the field of endometriosis and patient representatives. Although most of the studies have been confirmed by the previous ISHRE recommendations, but there are few areas where significant changes in the clinical practice can be expected. And there are few important gaps which were there in the previous version of guidelines have been added in this new one. Now, these are the changes in the current version, GDG and GPP, where the good practice points are included. So what about the diagnosis of endometriosis? So diagnosis of endometriosis is by cyclical or non-cyclical signs and symptoms, and all types of pains can be included in that, like right from dysmenorrhea to dyspareunia, dysuria, dyschiasis, painful rectal bleeding, hematuria, shoulder tip pain, catamenial pneumothorax, cyclical cough, hemoptysis, chest pain, cyclical scar swelling and pain, and fatigue and infertility. Although currently no evidence exists that reduces the time to diagnose or lead the earlier diagnosis, but what GDG says that it is better if you do a traditional history taking. So if you are good at taking history and if you have high index of suspicion in such cases, probably you will be able to diagnose endometriosis early. Now, clinical examination and diagnostic test. Vaginal examination is only to identify deep nodules or endometriomas. And there is a strong recommendation regarding the diagnostic workup with ultrasonography and MRI. Although the negative finding does not exclude endometriosis, particularly superficial peritoneal disease. Also, clinicians should not use measurement of biomarkers or the blood, menstrual or uterine fluids for the diagnosis of endometriosis. Although we have just heard regarding the use of biomarkers in infertility treatment of endometriosis, but this is what guidelines says. Then even with so much increased modalities in our imaging modalities have been improved so much now that laparoscopy is also has not been remained as a gold standard for diagnosis, and now it has only been recommended in those patients who have negative imaging results or where empirically treatment was unsuccessful or inappropriate. Now, what about the treatment about the endometriosis associated pain? So analgesics, again, it has a weak recommendation regarding that, but there is strong recommendation regarding hormonal treatment, like combined hormonal contraceptives, progesterones, GnRH agonist, and antagonist, which include oral, vaginal rings, transdermal, then progesterone-only contraceptive pills or LNG IUCDs, subdermal implants. GnRH agonist has a strong recommendation for the use, but evidences are limited regarding the dosage or the duration of the treatment, and always it should be combined with hormonal add-back therapy. What about GnRH antagonist? So it can be considered to reduce endometriosis-associated pain, although evidence is limited regarding dosage or duration of the treatment. But there are definitely strong recommendations regarding aromatase inhibitors, especially when pain is refractory to other medical or surgical treatment, and it may be prescribed in combination with oral contraceptives, progesterones, GnRH antagonist, and agonist. Then again, surgical treatment in expert hand is the option, and the preferred choice are excision, cystectomy, and laser vaporization. Currently, there is no prognostic markers that can be used to select patients that would benefit from surgery. Also, dinazole and antiprogesterones or antiprogestogens or laparoscopic uterosacral nerve ablation, that is LUNA, or presacral neurectomy and anti-adhesion agents for pain relief are no longer included in recommendations. Now, what about the treatment of endometriosis associated infertility? So there is a strong recommendation that clinicians should not prescribe oral ovarian suppression treatment or post-operative hormonal suppression or anti-inflammatory drugs just to improve natural pregnancy rate. Although there is a weak recommendation, but operative laparoscopy can be offered along with, in the cases where there is endometrioma associated infertility. Again, operative laparoscopy is quite valuable, especially in grade 1 and grade 2 endometriosis and endometriomas, which may increase their chances of natural pregnancy, although no data exists. And we just saw what Dr. Sujatakar madam has shown us, so many cases, and how it has improved the infertility. Now, the GDG recommends that the decision to perform surgery should be guided by the presence or absence of pain symptoms, or patient's age and preference, history of previous surgery, or presence of other infertility factors which can be treated simultaneously, or ovarian reserve and estimated endometriosis fertility index. Also, the cases where there is having extensive ovarian endometriosis, clinicians should counsel and discuss regarding the pros and cons of fertility preservation. And although the true benefit of fertility preservation in women with endometriosis remains unknown. What about the recurrence? So there is a strong recommendation regarding both hormone treatment and surgery. So when surgery is indicated, especially in endometriomas, you must go for ovarian cystectomy instead of drainage or electrocoagulation. And those who are not seeking conception, they should be offered long-term hormone treatment, which include combined hormonal contraceptive or LNG IUCDs for at least 12 to 24 months. Or also in the deep endometriosis and associated symptoms, again, post-operative hormone treatment should be considered. Now, those females who are seeking for conception, clinician can perform ART in women with deep endometriosis, as it does not seem to increase endometriosis recurrence per se. Lot of guidelines have changed in this endometriosis and adolescence. So although clinicians should take a careful history to identify possible risk factors, which include a positive family history, obstructive genital malformations, early menarche or short menstrual cycles, then you must inquire regarding whether she's missing her schools regularly every month, then is her dysmenorrhea has been treated with oral contraceptive pills. So these all should be taken into consideration, although it is a weak recommendation, but it should be done. Then before performing vaginal examination or rectal examination in such young patients, the acceptability should be discussed with adolescent and her caregiver, taking into consideration the patient's age and cultural background. Same is with the case of TBS. It should be recommended, but should be done after proper consent taking and counseling. And it is quite effective in diagnosing ovarian endometriosis. If that is not possible, then MRI, transabdominal, transperineal, transrectal scan can be considered. Again, serum biomarkers not recommended for diagnosing or ruling out. Now, in the cases where you are suspecting endometriosis, but imaging are negative and medical treatment is also not successful, in that cases, there is a strong recommendation to go for diagnostic laparoscopy. And this should be done by an expert, and you must always consider taking biopsies to confirm the diagnosis histologically, although the negative histology does not entirely rule out disease. For managing, first-line management treatment is through medical, mainly either LNG IUCDs or systemic hormones. And if hormone treatment is not an option, then NSAIDs can be given. And if hormone treatment has failed, then in that case, GnRH agonist can be given up to 1 year. But again, you must counsel your patient regarding potential side effects and long-term health risks. When you are thinking about surgical treatment, in that case, again, it should be done in the cases where patient has endometriosis related symptoms, and you must think that there may be a chance of recurrence, which is quite high, especially when the surgery is not followed by hormone treatment. And it should always be done laparoscopically by an expert surgeon. Then you must also discuss regarding fertility preservation, and you must take a informed consent and counseling about the potential detrimental effect of ovarian endometriosis and surgery on ovarian reserve and future fertility. But again, the true benefits, safety, and indications in adolescent remains unknown. Now, is endometriosis still active after menopause? So, although there is a weak recommendation, but very less data exists, but clinicians should be aware that it can still be active and symptomatic after menopause. And again, the surgical treatment should be given in the cases where patient is symptomatic and you have diagnosed endometriosis, because in this age group, they carry the higher risk of malignancy. Now, if the pelvic mass is detected in this age group, the workup and the treatment should be performed according to national oncology guidelines. And if surgery is not feasible, then aromatase inhibitor can be tried. Now, MHT in the postmenopausal symptoms in women can be given before, after natural or surgical menopause, but you must try to avoid estrogen-only regimens. And after surgical menopause, you can give low-dose combined pills up to the natural age of menopause. And these females are at increased risk of diminished bone density, dementia, and cardiovascular disease, so that should be kept in mind. Finally, in the asymptomatic endometriosis, the strong recommendation is that clinicians should inform and counsel women about any incidental finding of endometriosis. But clinicians should not routinely perform surgical excision or ablation, or should not prescribe any medical treatment, although routine ultrasound monitoring of asymptomatic endometriosis can be considered. And we saw one case just now with Dr. Sujata Madam has shown, where patient has conceived with such big endometrioma. And now the extrapelvic endometriosis, again, clinicians should be aware of symptoms of extrapelvic endometriosis, such as cyclical shoulder pain, cyclical spontaneous pneumothorax, cyclical cough or nodules, which enlarges during menses. And it is advisable to discuss diagnosis and management of extrapelvic endometriosis in multidisciplinary team in a center with sufficient expertise. For abdominal extrapelvic endometriosis, surgical removal is the preferred treatment when possible to relieve symptoms. And if it is not possible, then hormonal treatment can also be an option. For thoracic endometriosis, again, hormonal treatment can be offered, but if surgery is indicated, it should be performed in multidisciplinary manner involving a thoracic surgeon or other relevant specialists. Then, although there is no direct evidence of benefiting in preventing endometriosis in future, but definitely women can be advised of aiming for a healthy lifestyle and diet with reduced alcohol intake and regular physical activity. So primary prevention is aimed at protecting healthy asymptomatic women from developing endometriosis, but definitely the usefulness of hormonal contraceptives and other drugs to prevent primary prevention of endometriosis is uncertain. Even genetic testing in women with suspected or confirmed endometriosis should be reserved only for research purpose. Now, although endometriosis is not associated with significant higher risk of cancer overall, but definitely we must be aware that it is associated with the higher risk of ovarian, breast, and thyroid cancers in particular. So GDG recommends general cancer prevention measures, which include avoiding smoking, maintaining a healthy weight, exercise regularly, having a balanced diet with high intake of fruits and vegetables and low intakes of alcohol, and using sun protection. There is very little evidence that somatic mutation with deep endometriosis may be predictive of development and progression of ovarian cancer. So clinicians should be reassuring their women with endometriosis about the risk of malignancy, associated with the use of hormonal contraceptives. Then clinicians should also consider cancer screening according to local guidelines in the individual patient who have the additional risk factors like strong family history or specific germline mutation, but definitely not for all patients. Then there is a epidemiological data, mostly on endometriosis, ovarian endometriosis, showing that complete excision of the visible endometriosis may reduce the risk of ovarian cancer. And the potential benefit should always be weighed against the risk of surgery, like morbidity, pain, and ovarian reserve. So these guidelines will help us to mold us in managing our endometriosis better. And what we have been listening for last 2 sessions, that who knows endometriosis knows gynecology. So we must keep updating ourselves with these recent guidelines. Thank you so much.
Dr. Priyankar, are you there?
Yes, ma'am. Yes, ma'am.
Yeah.
Thank you so much, Pratibha ma'am, for that wonderful talk. The main important highlights that you talked about, all the recent updates was quite very important, especially the things that we need to do with endometriosis, which the atypical endometriosis as well. And plus, I would say with the HTA guidelines, of course, since we at present do not have any particular guidelines which we can talk about FOXI guidelines or Indian guidelines, most of us tend to follow the HTA guidelines, and that is why the importance of this talk. Thank you, ma'am, for enlightening the same. And I would also request all the viewers who are present over here, like the updates that she has said. So always remember, we definitely have our own experiences in our clinical practice. But remember that when we follow the guidelines, be it whatever guidelines or the textbook, we are always medically safe. And that is something that is very important. And that is the take-home message I would say of Pratibha ma'am's talk. Thank you, ma'am, once again for the wonderful talk.
Thank you. Thank you.
Chintan, you joined late, but would you like to make some comments, sir? Dr. Chintan?
Yes, ma'am. Yeah, sorry, I was in emergency, so am I audible?
Yes.
Madam, I could very well attend the last 15-20 minutes of your lecture. And as Priyankur sir said, I mean, that guidelines, we know everything, what to do and when to do, but what the guidelines say, that's a very, very important part in this. And, the few important aspects like postmenopausal, endometriosis or extrapelvic endometriosis, it was really something that we need to know about, because since endometriosis is a disease which is spreading just like a cancer or malignancy in females, and it's so, I mean, painful and a crippling disease that whatever we know about this disease is probably less in these times. So thank you very much for madam for very wonderful inputs, and we really enjoyed.
Thank you so much, sir. Thank you, Monica. Thank you.
Yeah, thank you so much, ma'am. It was a wonderful talk. So let's move forward for the panel discussion. Dr. Neetu Mishra, ma'am, would you please take the session forward?
For the panel discussion, good evening all. For panel discussion, I want to invite the panel moderators, Dr. Monica Singh ma'am, who is the convener of this series, and Dr. Manisha Jain ma'am, who is, I guess she is traveling. So in place of her, Dr. Purnima will be moderating this session. And for the panelists, we have, can you please run the slides of the panelist? Panelist, Dr. Hiral Pandya madam is there. She is Secretary, Bharuch OBGY Society, and she is working with Shevashram Hospital, Bharuch. Welcome, ma'am, for this panel discussion.
Thank you, ma'am.
Our next panelist is Professor Dr. Nidhi Johri, ma'am. She is professor and head of the department, Saraswati Medical College, Lucknow. She is currently Secretary, Lucknow OBGY Society, and she is past treasurer of Lucknow OBGY Society from 2017-18 and 2020. And she was also treasurer AICOG 2020 and UP COG 2023. She is Chief Consultant, Hope Mother and Care Center, Lucknow, and her special area of interest is bad obstetric history, menopausal medicine, and infertility. Welcome, ma'am, to this panel discussion. Our next panelist is Dr. Rekha Singh, ma'am. She is alumni of LLRM Meerut and KGMC. She has, after senior residency from Safdarjung and DDU Hospital, she had training in laparoscopy, colposcopy, and USG from Delhi. She held Office of Secretary Foxy, Muzaffarnagar branch for 2 years and delivered lectures on cesarean section and adolescence and sex education in Muzaffarnagar. She also participated in online COVID awareness with Abhivera Foundation. We welcome you, ma'am, for this panel discussion. Our next panelist is Dr. Richa Paharia. She is currently senior gynecologist and obstetrician with 22-year experience in District Hospital Narmadapuram, MP. She is also president of Narmadapuram OBGY Society. She is member Sexual Health and STI Committee Foxy and master trainer for adolescent reproductive and sexual health, gestational diabetes and maternal death review. She has expertise in high-risk pregnancy, cancer prevention, anemia prevention, adolescent and menopausal health, and extracurricular. She is very active in extracurricular activities. She has national level rifle shooter, and she is also a professional Kathak dancer. We welcome you, ma'am, to this panel discussion. Our next panelist is Dr. Sapna Jindal. She is Secretary of Foxy Palwal and consultant at Anmol Hospital Palwal. We welcome you, ma'am, to this panel discussion. And last but not the least, our next panelist is Dr. Varsha Lahade. She is Director of Prayag Hospital, Nasik, immediate past President, Nasik OBGY Society, and Zonal Coordinator for EMOX. She is also past Organizing Secretary for NOGS, past Joint Secretary for IMA, and National Faculty for Gestosis. So a very warm welcome to ma'am for this panel discussion. Now over to moderators for the panel discussion, please.
Thank you, Dr. Neetu, for introducing all the panelists and for introducing us. So we come to the most interactive part of the session today, that is the panel discussion, in which all the lectures of our speakers will be, put to test, because here we will come to know how much attention you were paying to the evidence, how much you were able to, change your viewpoints, your practice points, and what carry home you will be taking from here. So my co-moderator is Dr. Manisha, and in her place, Dr. Punima is joining me as a moderator. And we have labeled our panel discussion as We Are the Endo Warriors, because we are basically waging a war against endometriosis. So I would like to call it as, we are endo warriors, and we are always trying to better our treatment strategies. So we know that we have heard about so many guidelines from our speakers. We are right on page with the ESHRE guidelines, how they have modified our viewpoint. NICE has given a lot of guidelines. Recently, the Australian Society of Obstetricians and Gynecologists has also modified these guidelines. And Dr. Sujata has given us a fair insight into how surgery can help. But still, endometriosis is a riddle wrapped in a mystery inside an enigma. So it sounds like a Sherlock Holmes novel, but it's important to understand every individual case of this disease, because when you're sitting in your hospital or your chamber and your fertility center or a general gynecology OPD, you will be faced with only a patient. And that patient might not fit into any criteria you have heard. So here the guidelines will come into play, because whatever you do by evidence will go a long way in improving your practice. This is how endometriosis is being searched on the net. In PubMed, you can see the amount of searches which have increased exponentially from 1950 to 2024. So this graph only tells you that this disease is increasing by leaps and bounds. So though it is benign and estrogen dependent, it's a very progressive disease and behaves like malignancy and never fails to interest all of us. So we know about the prevalence and the, how much is the incidence in infertile women. But I would like to ask from my panelists, all of them, that how much is the percentage of patients out of infertility patients you see in your practice in your part of the country? And how much patients of endometriosis do you find in the general gynecology OPD? All of you can answer, like there is no order. You can just join, all of you.
I think it's a very, very common problem these days, because in the general gynecology, if we see, so many people are coming with the problem of, and especially in young girls coming with dysmenorrhea. Many of them come up as it's so evident over the counter mephtal spas kha kha ke. But once we go in for the investigations, endometriosis is very high. When we go in for USG, many of them have this comes up as endometriosis. And in the infertility also, I think around 10% of the patients with infertility, I would say generally, I mean, in whatever I practice, very little, I find endometriosis is a part of it.
Yeah. So anybody else with a different, like your infertility patients, when you see, like suppose you see in a month, uh, total infertility patients 10, how many endometriosis cases would you find? 10, 20, 30, how many patients you see? Do you find endometriosis there, Dr. Hiral? And what makes you suspect, Dr. Who are the other panelists here?
Ma'am, if I'm seeing on an average 10 patients, then at least 2.5 turns out to be endometriosis. The main symptom is dysmenorrhea right from the age of menses, which has been taken, proceeded till reproductive age, which has been cured by, as our man told, by the OTC counter of mephtal spas, and still the degree of dysmenorrhea is increasing. And the another important finding is dyspareunia associated with dysmenorrhea with infertility.
Yeah. So, etiopathogenesis is definitely important. We have been reading from our gynecologic textbooks about these retrograde menstruation theory, hematogenous, lymphovascular. Just now, Dr. Nirja Bhatla told us about estrogens, xenoestrogens, which we are consuming through dairy products. So these are all the theories which are working, and that is why the biomarkers have come. So there is any theory which is of relevance today? Dr. Sapna, would you like to comment? Dr. Hiral? Or
Yeah,
yeah.
good evening, ma'am. Out of 10, 1 or 2 patient comes of severe dysmenorrhea.
And what according to you, you must have prepared for the panel, Dr. Sapna, what according to you is the most relevant theory of etiopathogenesis, origin of endometriosis? How does it occur? Is there any?
First, only dysmenorrhea, patient comes with dysmenorrhea. Then after diagnosing, doing ultrasound and TBS and all, we come to, after if she's married, then primary infertility also.
So what do you think? Is there any role of genetics? Do you think there is a familial disposition in the occurrence of endometriosis? Dr.
Ma'am,
Yeah, do you think there is, do you see endometriosis in daughters of patients who have endometriosis? Have you ever encountered? Dr. Richa, what is your opinion, Dr. Hiral?
Yes, I think familial
Yes, ma'am.
disposition
Yes,
is
ma'am.
very
Genetic
much there.
predisposition is
Because
one
when
of the
we go in for history, sorry, when we
Yes,
go
so
in
that
for
is very important. Like
that is
if
very
you find,
important,
yeah,
especially
please carry on.
mothers, sisters. We have to, and whenever we are taking the history, when a young girl comes for dysmenorrhea, we should always inquire about these things, because that also gives us that gives a clear disposition that the girl might have endometriosis, which we are ignoring as a normal dysmenorrhea case. And when we, even for infertility patients, that should always be taken care of. And the history part should be very clear, because it has a known familial disposition.
So what according to you, Richa, Dr. Richa, suppose an adolescent comes to your OPD with history of severe dysmenorrhea, missing school days at regular intervals in the month. what are the 3 risk features or 3 to 4 risk features in our history which will make you suspect endometriosis? One, you have already said a family history. Anything else?
Family history, dysmenorrhea, severe pain, lower abdominal pain.
This
And
patient also
Painful
had short
defecation
menstrual
also.
cycles.
We should consider painful defecation.
This patient is also prone to endometriosis in case she has got shorter menstrual cycles at the time of menarche and
And
early menarche.
if she started off with her menses very early in the
Early
age,
menarche,
she has
yes.
early menarche, that and the cycles, I think you've already mentioned.
Yes, so these
Cycles
are mentioned actually in ASHRAE guidelines. I'm speaking only of guidelines because we do not want to spread any message which is out of evidence. So just to revise, any adolescent girl who comes into your OPD with complaints of dysmenorrhea, missing school days, maybe, even vomiting, nausea, she has fatigue, unexplained aches and pains. So don't take her as functional. Always take the family history. Ask her about the period of the time of menarche. Ask her what the short cycles are, whether the cycles are short, and how do you define a short cycle here, Dr. Richa? What according to you is definition of a short cycle?
less than
cycles
less than 15 to 20 days, in between 15 to 20 days,
Less
ma'am.
than 21 days.
Dr. Manisha, if the
Less than
cycle is
21
less than
days is a
21
short
days
cycle.
in duration, then it is a short cycle.
What did you say, Dr. Nidhi? Can you repeat, please?
A cycle which is shorter than 21 days in between is a short cycle.
Exactly. Very
And
nice.
you will nowadays, if since we know that there is a lot of genetic predisposition, so we find also, because if we see and interrogate the adolescent girl coming with dysmenorrhea and painful periods, and the pain is so much that she has to skip her routine duties, and the cycle is short, then immediately it comes to our mind that maybe the mother also had this kind of problem. And then when you investigate, you find out that yes, there are problems.
Yeah, exactly. So after this short introduction is over, the infertility part naturally we'll be discussing more in detail. But based on this adolescent problem, Purnima, can you take case number 1, please?
Yes, ma'am. Yes, ma'am. Thank you so much, ma'am. So now let's move forward for case number 1. This case is of 19-year-old girl, Miss Agony, complains of severe dysmenorrhea since 2 years. Her periods have become more painful recently, which often makes her miss her classes, and she has to resort to medications for pain relief. She visits OPD and consults for the same. So how would you proceed further?
Now,
In
this
the
is
first
what
thing
treatment.
we'll take the
Richa,
history.
how are you going to treat basically this girl?
The first thing that we would do will be we will be taking a detailed history so that we can come to the right conclusion. And the second part will be the clinical examination, of course. We'll do a per abdomen, and as she's only an adolescent of 19 years, which I consider from this that she's unmarried. So we will not do a per vaginal examination, of course. So we'll take the history, if it points towards endometriosis or otherwise also. The second thing that we would do is we would take her for an ultrasonography. And if she has the findings, generally we can find them. If it's only very superficial, then of course we might not find in the ultrasonography. Otherwise, ultrasonography will suggest us. And the next part will be that we'll be going in for the treatment part. In the treatment, as she's just an adolescent, we'll advise her about the dietary regulations, because as was mentioned, the diet and the environmental pollutants, so whatever can be avoided. And other than that, we can start her on an SAIDs. And as she's a young girl, I would start her on oral progesterones. I think that would be the first line of treatment for her. And so that she does not ovulate, so that we can stop not the ovulation part, because we will be increasing the progesterone and decreasing on the estrogen part. So
Yes,
that will give relief to her pain.
Very true, ma'am. As Monica ma'am has already told that what are the symptoms of endometriosis. One important, very important thing, which we should keep it in mind, that this girl can present with non-cyclical and cyclical pain. She can present with dysuria, dyschezia, painful rectal bleeding, or hematuria. So what happens many times that these girls end up in gastroenterology OPD or the urology OPD, and this diagnosis missed many times. So we have to ask about all these symptoms also whenever a girl is presenting with dysmenorrhea. And they can have shoulder tip pain, catamenial pneumothorax, cyclical cough also, chest pain, and cyclical scar swelling and pain. Has the detailed history is very important in these girls. Next slide.
Any of you would like to do a per rectal examination under any indication? Because, naturally PV in India for like even if this girl has had sexual relation, her parents or her guardian would not like us to do a per vaginum examination. But I'm regularly getting college students who are
Tanisha, that's very common. You asked a very good question.
Yes.
And in some patients, if the symptoms for which the girl has come, they are increasing in the intensity, like the pain is increasing, the cycles are becoming still shorter, we should resort at times to per rectal examination. Because in any case, we are not going to do a per vaginal examination, but per rectal examination gives us a lot of information if we do. So in some patients where we find that patient has the symptoms are on the rise, and then the patient is also in pain, and we really don't we have a very good setup where we can send the patient for a better investigative battery, then the best is to do a per rectal examination.
Yeah, so that's what like I wanted to stress, that we should not shy away from a PR examination, because very many times the imaging would be negative. Just tell me, how many under 20 or under 22 women have you done a suspected endometriosis and found a positive finding? Because it's very rare, because they just have that superficial disease, ASRM stage 1 and stage 2. So this superficial disease is actually peritoneal disease where imaging will be negative, and you just have to work with a high index of suspicion and not.
That is very
That
correct.
is true.
Very
That
correct.
is true. Yeah.
Yeah.
Even
So
the biomarkers are not very reliable, although the newer guidelines, and it is very difficult to get them done also. They're pretty expensive, not easily available, and it is not very pathognomic that if we do a biomarker for all the like inflammatory conditions, we do IL-6/8, so we will get a pathognomic diagnosis of endometriosis. So basically, endometriosis rests with our history part and the examination part, which in young girl who's not married is a per rectal examination.
Yeah.
Yes, and
Dr.
as such, even biomarkers are not recommended by the guidelines as well.
Yes.
The guidelines says that we are not supposed to do the biomarkers only for the purpose of diagnosis.
That they are not pathognomic. They might be high in many other situations as well.
Exactly.
Like yesterday, Purnima and I, we were discussing this panel because we always like to have a discussion before going live. So Purnima just said, "Ki madam, there is a hospital over here. They are advising, biomarkers for endometriosis, and the patient underwent, I think, MMP. MMP, the biomarker. Just now, Professor Zeng also told us. So see, these are corporate hospitals will just like the machinery to run. So outside of a research setting, I think if when AIMS Delhi, Dr. Nirja Batla is sitting and she wants a postgraduate to do a thesis on endometriosis biomarker, then the institute will take a blood sample from every suspected patient and they will subject that to a randomized control trial. Okay. Outside of a research setting, in a private practice or in a busy hospital, doing biomarkers is not the message we want to give. But we have to see how biomarkers evolve in the next decade. Maybe there is something of value which can prognosticate and predict the disease, Dr. Nidhi, before time.
So that's basically when we do, still, we don't have any study on a larger basis where we can recommend that we do a marker test and then we can predict that the patient might be having endometriosis in the later stages of life, like screening method. And moreover, as you already said, Manisha, that most of the time it is not available and it is very expensive.
Yeah.
So in everybody's setup, getting apart from the corporate sector, it is not easy for a to use biomarkers as a screening method, because as a screening method, then the patient, you will have a lot of difficulty
Right.
first to
And
get the investigation done,
right.
and then convince the patient that it is basically for prognostic values.
Yeah, so it is something like the BRCA test, just testing for
Yeah,
CA.
correct.
Probably down the line, if I have endometriosis and I conceive with difficulty and I have a daughter who is 11 or 12, I'd probably, if biomarkers, if I'm in 2034, I would like to do a biomarker test for my daughter कि इसको endometriosis तो नहीं होने वाला. That might be a possibility after 10 years or 5 years. Let us see. That might become just a diagnostic test, something predictive in a positive family history or for a concerned mother or a concerned guardian. So just it's a hunch. It just came to my mind. It was not
Yeah,
planned.
But
very
I
true.
don't know how is
Very
it going to help, even if we predict that this person might have, but
Richa, you will put her early on hormones.
Hormone therapy.
You will
Yes.
put her on low dose progesterone or COC. That girl will not miss school. That girl will not waste time on diagnosis. She will not waste money on MRIs and things. Then when she gets married and finds a partner, she will plan her fertility intelligently. She'll be able to tell her doctor that she's a probable case of endometriosis. Her mother had chocolate cysts. So many things can be just worked out. It's just like how you basically predict the future to be.
yeah, let's see the endo chip which he was showing. If it works out, I think that would be great.
That
Yeah,
is the
in the
thing.
near future.
So that's the whole purpose of a panel. Basically you get all the minds together, and we also learn so many things after studying such a lot. Anybody who has experience in putting a scope in an adolescent or a young woman before marriage, and when did you do it? What was your finding? What's your experience?
Ma'am, I have got two sisters. One sister was married with a huge chocolate cyst, and the
Okay.
younger sister who was not married, again with a huge chocolate cyst bilaterals with severe dysmenorrhea. And
Your
she
sister?
was just engaged.
Your
We planned
sister?
yes. Both sisters, no, two sisters, both were my patient. One was married and one was unmarried.
Who is this? I can't
And
see.
we did laparoscopy in both the sisters.
Okay. Who's speaking? Which panelist is this? I'm not able to see actually.
Yeah.
Ma'am, Hiral.
Yeah.
Okay.
Hiral.
Yeah. So,
And ma'am, that sister, the sister who was married, she had a unilateral chocolate cyst with endometriosis, having dyspareunia. She got pregnant after 6 months of this treatment. The younger one who was unmarried, but she was having severe pain for which we did endometriosis laparoscopy for that. And later on, her fiance was called. Everything was explained about blue MH, decreased fertility, and everything. She got engaged and she was planned for IVF immediately after marriage. She was immediately planned for IVF because of low MH, and she conceived.
okay. So that is
So
the
Can I add,
I
Monica?
have also one, Manisha, I have one patient. She was young and she was engaged. And when and she was in great pain. And the pain was very bad. Her mother had earlier died because of some malignancy. She didn't knew. She was from Uttarakhand. And then I did a laparoscopy in this patient, and then I saw that exactly she had a very bad endometriotic chocolate cyst, and the pelvis was very bad with endometriosis grade 3, grade 4. So we just the very important thing was that she was already engaged, so we could explain this like she has already told, that we explained the fiance about the AMH part, about the fertility part, and within 6 months she conceived automatically. I didn't know what happened.
So what are
Yeah.
the
Can
what
I
does
add, Monica?
yes, Varsha ma'am.
Yeah.
Welcome, ma'am.
Yeah. Thank you.
Yeah.
Thank you. Sorry for that being late. Little stuck with some
No, it's
commitment.
okay. It's
Yeah.
okay.
Yeah. Previously, what we used to do, we used to weigh the pain factor as well as the findings of local findings of the endometriomas, which in young girls we used to see. Previously, we used to go ahead with, if she has pain, we used to put a scope. But nowadays, we have to think twice before putting a scope. We have new modalities, we have drugs in our hand, and we are in view of preserving the ovarian tissue or oocytes. So nowadays what I think is before that, we have to reduce the pain with the drugs, and then we should go for ovarian preservation in these young girls.
So
And then if
yes.
at all we want to just do the pain factor, we do it little later, not
Yes.
immediately.
So can anybody tell me who has read the guidelines? What do ESHRE guidelines tell you about putting a scope in a young patient? What is the definite indication according to ESHRE guidelines? Purnima, have you read?
Yes, ma'am. So
Any,
it is
one sec. Any panelists would like to say, or we would ask Purnima to do it?
It is no more a
Ma'am,
gold
I would
standard.
say
Actually,
that
laparoscopy,
dysmenorrhea.
which was previously considered
It's
as the gold
there is a
standard,
fixed line. It is a fixed statement. It is a guideline, and ESHRE has got very fixed guidelines. So we have all given opinion. It is all a mix of that opinion. ESHRE guideline exists. So Purnima, can you tell us?
Yes, ma'am, it is written here also. In patients with negative imaging, suppose if we ask this girl to undergo ultrasound and the finding is negative, and if we have given the empirical treatment also for endometriosis, but it is still unsuccessful, then it is recommended that clinicians consider offering laparoscopy for the diagnosis and treatment of suspected endometriosis.
So this is the guideline which tells you everything. Can you see my laser pointer? In women, in girls, where you have got a high index of suspicion that is she's clinically endometriosis, all the imaging is negative. You have given empirical treatment in the form of NSAIDs, that is also unsuccessful. Then the guidelines recommend that you should consider offering laparoscopy for diagnosis and treatment of suspected endometriosis, never only for diagnosis alone, always put a scope with an intention to treat also. So this is a good practice point which ESHRE says. So we now move to the next. Now for diagnosis, laparoscopy is no longer the diagnostic gold standard. And here where it is indicated, we've already said. Okay, Purnima, you can proceed now with the
Yes,
case.
ma'am. Yes, ma'am. So next slide.
Yeah.
So we have already discussed about the role of biomarkers in endometriosis, and we should not use biomarkers just to diagnose endometriosis. And
Neither in the endometrial tissue nor in the blood of the blood sample taken, menstrual fluid or uterine fluid. And these fluids like peritoneal fluid, which Professor Zeng told us is pathognomonic of endometriosis, especially superficial disease, is rich with all these, biomarkers.
So how sensitive is ultrasound in detecting endometriosis?
Now there are two types of endometriosis, stage 1 and 2 and stage 3 and 4. Where would you do ultrasound? Where would you not like to do ultrasound? Anybody?
First and second, of course, because it will not be very helpful. The superficial lesions, we will not be able to find them out in ultrasound. And of course, in 3 and 4, the deeper lesions and the endometriomas, we'll be able to diagnose better in ultrasound.
So, Dr. Richa, what is the phenotypic classification of endometriotic lesions? Phenotypic classification is there nowadays. According to the location, phenotypic.
According to the phenotypic, it may be peritoneal. It is divided into 3. The first will be peritoneal when the lesions are found on the peritoneum. Superficial, deep, whatever. And the second is in the ovary.
That is only superficial. Peritoneal is purely superficial.
Peritoneal.
Second is
ovarian.
Ovarian is endometriomas or omas. Third is deep.
Yeah.
So what is funny is that the best ultrasound sensitivity and specificity is in the ovarian endometriosis or endometrioma for obvious reasons. For deep endometriosis and for superficial endometriosis, usually imaging has got a poor sensitivity and specificity. And there you would like to do surgery, in fact. I mean, if you put a scope, you'll be able to diagnose a superficial endometriosis better rather than ultrasound or MRI. And for deep endometriosis also, a surgery sometimes works better. Like Sujata ma'am had told us so many cases where puckering and that scarring and the, stuck ovaries, even though HSGs, very surprisingly, these patients show a patent tubes on HSG. But when you put the scope, you see all sorts of distorted anatomy.
And where we can't do transvaginal ultrasound, we can go for the transrectal ultrasound.
Yeah, yeah. And definitely MRI. MRI is nowadays not very super expensive. In fact, there are many patients who say yes for MRI, and MRI may have, a slightly better sensitivity and specificity. You can demarcate the lesion. But of course, when it comes to superficial disease, no imaging modality has got superior diagnostic value as compared to laparoscopy, because we read about those classic powder burn lesions and the small spots which you can see with naked eye and probably start the treatment. So we've talked about management of this girl. Can you summarize the management, any of you? Adolescent girl missing school. Can you summarize the treatment? How will it go?
Dr.
Varsha?
Hiran?
Yeah.
First, initially, madam, we will dietary planning, take the diet accordingly. Weight reduction is exercise, and in starting we will start with NSAIDs. If it controls, then okay. Otherwise, we will give progesterone.
Yeah.
So, for summarization, we will first investigative part. For investigations, we just, if the patient, usually for the first or the second time, we don't do a major investigation. Like a simple plain ultrasound, if it shows something, it is good. And for managing the pain, the first line of treatment is NSAIDs. Then you can give progesterone, or in some patients, COCs.
Yes.
COCs, low dose COCs. And if the pain is still not, because we have to conserve the ovary, conserve the ovas. And then lastly, if we are standing nowhere and the patient is complaining of severe dysmenorrhea, which is increasing every day, not responding to NSAID, then only we resort to laparoscopy.
Yeah. So we have definite indications for laparoscopy. We have to tell the patient, motivate the patient, and basically, prognosticate the disease progression to the guardians of that girl, and of course, the girl herself. So that finishes with the adolescent patient case. Now, second case is a 27-year-old professional. Yeah. So this is a 27-year-old professional is married for 3 years, and she is also experiencing dysmenorrhea and dysmenorrhea off and on. She's got regular cycles. Now she comes with her partner in the OPD because now they want a baby, and they've been trying seriously for a year or more, and she has never used contraception. So after taking all that history, you already have your, basically index of suspicion high. And on TBS, the only significant finding is that fixed retroverted uterus and probe tenderness. The semen analysis is unremarkable. So, what are the causes of infertility in this case, and how does endometriosis basically affect the reproductive function? And
Patient glitter.
yes, and how does it cause all the problems in her in conceiving?
Good
You can
evening, ma'am.
take yeah, you can take the help of the slides also. There's no,
Yeah.
yeah.
Yeah. This is the patient is infertility of 2 or 3 years, and first we goes through the transvaginal sonography, and findings are suggestive of. Then later on we go to infertility panel, infertility hormonal levels, AMH, serum prolactin, and thyroid, and we see what the level of AMH, and if there is a fixed retroverted uterus and sliding sign is negative, we go for the, if AMH level is good and patient is trying and semen analysis is good, then we go for laparoscopy.
In a fixed retroverted uterus, would you like to go straight away for a laparoscopy, operative laparoscopy, or would you, anybody who would suggest an HSG?
First HSG, and because there is a fixed retroverted uterus, even tubes are patent, there is a chances of infertility is due to the fixed uterus, and because of tubo-ovarian relationship is not good.
I think in
Actually,
this kind of a patient, I would straight away go for an IVF. With the retroverted uterus, the chances, even after a laparoscopy and the surgeries, just as we found out, if the surgeon is very good and if see, the first surgery has to be very, very good. And this
Yeah,
in
yeah.
this kind of a patient with fixed retroverted uterus and with tenderness and everything, the chances are that, well, first we'll have to investigate, of course, and find by the ultrasound how things are. But just putting a scope to make a diagnosis will not help her very much, I think.
You have to, if you do a scopy, you have to do with intention to operate. You
With
should be
intention to
able to at
operate.
least,
And
at
it
least,
should be done in very, very good hands.
yes.
So
Because
I
we
agree
cannot
with
just,
what you are saying, Manisha. I think the best thing is not to put a laparoscope in such patients. And if by your clinical acumen and judgment, you can find out HSG, definitely you can do. It is non-invasive. And but still, since the you have told us that the retroverted uterus, fixed uterus, and then y- if you want to do any kind of surgery and you think that you can do it so well, only then you introduce a scope. Otherwise, you should not do it. That is what I think the lines also say. Unless and until you are sure of doing a surgery to make the uterus mobile.
Yeah, if I also think, Dr. Richa, let us not be very, adamant about it. Suppose on TVS you see good ovaries, good follicles. She doesn't have an endometrium on either side. Okay, you can, there is slow probe tenderness, but you just are able to see a good endometrium. That patient is not willing for a scopy. So we do an HSG and we find bilateral patent tubes. And she's only 32. Won't we like to do 2 or 3 good cycles of controlled ovarian stimulation with
That
IUI?
is what I was also of the opinion that
I would have said that now that
Yeah.
instead of putting the scope, we can go in for the other methods.
Yes. You know what? Because we have seen some very bad cases. In fact, I have seen
getting
IUI pregnancies in stage 3 also. Stage 3 cases who were referred to me for IVF only. But that patient I found, her to be 31, 32, 33. Basically, that Poseidon 3, unexpected poor responder, young patient. So just took her for tubal patency testing, subjected a good controlled ovarian stimulation with IUI and aim for about 2 follicles, sometimes even 3 we have done IUI. Though 3 follicles is nowadays not done, but we have easily done with 2 and we got pregnancy, though it's very rare. But I think it's a fair chance to be given to the patient if it is less than
Ji,
35.
it is, I think you are very correct. And these patients, I don't know how they conceive, but if you have a very good controlled cycle, at least they should take the benefit at least of 3 cycles. If the HSG shows that they have patent tubes.
Yeah. So that is, I think endometriosis is a disease which spares the tubes. And on the other hand, female genital tuberculosis is something which will damage the tubes even though the tubes appear normal.
That is
These,
the basic
Very right,
difference
very
between
right.
between the approach to a tubercular pelvis and a endometriotic pelvis. So usually we find that HSG shows good.
Dr. Nidhi, can you please elaborate the difference between a tubercular pelvis and an
Sure.
endometriosis
Yeah,
pelvis?
sure. So if we start from the signs and symptoms, the clinical present. If we start from the symptoms first, the first symptoms which we see in endometriosis is dysmenorrhea, where in tubercular infection we really don't get so much of dysmenorrhea. That is the first difference in the symptoms. Clinically, what we can which will arise us for some suspicion that the patient might be having a tubercular lesion. The second point is that the cycles in tuberculosis, we all know that if the tubercular infection has long standing, that there might be synecdoche and the flow of the fluid might be less. Whereas in cases of endometriosis, you find short cycles, good amount of bleeding, dysmenorrhea. All these are actually not seen
And you
much.
in tuberculosis, you might have history of contact. If you
Huh.
do
That's
elicit
very
the
true.
history,
Yeah,
yeah.
that's very true. That's very true. That's very true. So first we talk about symptoms, and then later on when we do, if the patient is not married, and we can find a contact who has or tuberculosis contact or something like that, then the suspicion and the most of the time it will go in favor of tuberculosis. Whereas dysmenorrhea for endometriosis, a family history, genetic finding in mother or sisters can help us take the diagnosis to another level. The second, then doing a per rectal examination will make us very clear whether we are dealing with a tubercular patient or we are dealing with a endometriotic patient, because clinical findings are absolutely different for both of them. Just doing a clinical examination, and then the general stature of the patient might show some tubercular infection type of things, loss of weight, loss of appetite, something like this.
And that dysmenorrhea and dyspareunia thing will be completely absent in the
That is
history.
what that is the symptoms I told. The patient was not telling us
You will
this.
have more of constitutional symptoms, maybe.
That is what I say. I am saying that loss of weight, loss of appetite. You can see the stature of the patient. The patient might look sick, toxic in
Yeah.
in tuberculosis.
Actually,
And
Dr. Reddy, we started talking about this because of
uh,
the tubal assessment.
Excuse me,
yeah.
ma'am. Ma'am, I have an emergency. I'll be joining with my phone in some time and I'll be rejoining.
Sure,
Thank
sure,
you.
sure,
Thank you so much.
Sure, Dr. Richa. Thanks for your inputs. So this is how HSG should not be totally done away with. HSG for tubal patency is still a very useful investigation in endometriosis, and you might get a pregnancy with a good cycle of controlled ovarian stimulation with IUI. We've already talked about the different clinical phenotypes with the endometriosis, and now we'll see a little bit about the classification systems. So when you do clinically the diagnosis of endometriosis in your ovary, please keep in mind that it's either the superficial or ovarian, that is endometrioma, or it is deep endometriosis. And always your index of suspicion should be very high. We all know about revised ASRM classification. Anybody can just tell us about this classification, please? Any of the panelists?
Yeah. Yeah. Can I take? Somebody else is saying.
Nidhi, can somebody else take the question now? Because, yeah, we have Sapna, we have Varsha madam, and we have who, madam, can you identify Oppo phone? Who is, ma'am, yours is in a green suit? You're muted. You're muted.
In stage, it can be classified into minimal, mild, moderate, and severe. And here we into consideration peritoneum and ovary. If it is minimal in peritoneum, it might be superficial endometriosis, say 1.5 centimeter, and a single ovary involved with a superficial endometrioma and somewhat adhesions. If it is moderate, it involves a second ovary, the contralateral ovary with minimal of endometrioma, and we can see the increase in the size of endometrioma. So it may increase up to 3 or 4 centimeter in peritoneum. It is stage with moderate. It is peritoneum with both the ovaries and with deep endometriomas in both the ovaries. And if it is severe, then we can see even tubal involvement also. And if it is the severity is more severe, then we can see even the involvement of cul-de-sac and everything.
Okay, and you know what? When was this revised ASRM classification given? You remember the year?
1996.
Yes, it's a very old classification, but it is still holding true. The only difference is that now we have got, the endometrial fertility index for the ART people and for infertility. And of course, our revised ASRM classification still stands. So any other classification we are still using, Purnima?
Yes,
Where is-
ma'am. Yeah.
What
So,
would you like to speak about classification systems? You have read the topic a lot. Which classification systems do you think are clinically important?
ma'am, as for fertility point of view, I think the EFI is the most important whenever we are doing surgery now. But recently, it has been proposed that EFI can be calculated even without doing the surgery as well by the non-invasive methods. And the another one is NZN classification of endometriosis. So, should we ask any panelist about the NZN classification?
I think Enzian classification is also like the same thing. The only, what is the difference between Enzian and revised ASRM? Anyone? It is actually Enzian is not used much. It's also classifying the disease into peritoneal, peritoneal, deep and very deep. But I don't think we are using much of it practically. So we'll skip this, Purnima.
Yes, ma'am.
Yeah. Now, this patient has got patent tubes on HSG, and Dr. Nidhi, you have planned for IUI.
Right.
What is your choice of stimulation in this case? She's 32 years old. Her antral follicle count is 3 to 4 in both the ovaries. Her AMH is 1.7, and she's got bilateral patent tubes, and sperm count is 45, motility is 40%.
So AFC is 3 to 5.
3 to 4 in antral follicle count is both the ovaries have got 3 to 5 antral follicles. So the count is about 8 to 10.
So 8 to 10. So I
Yeah.
would just like to do a plain simple IUI.
Okay, so which panelist says that a simple IUI should not be done in known cases of
Yeah,
endometriosis?
whenever you go for an IUI, it has to be along with control ovarian stimulation and IUI, because the results are better with this, and don't waste the cycles and time of the patient doing
Yes,
alone
ma'am.
a IUI.
Yeah.
No, yes, IUI should not be done alone.
Yes. So the evidence says that if you are planning for IUI, please associate IUI with good controlled ovarian stimulation, which could be oral ovulagens. Even better results are there with gonadotropins, or if you have got good experience, you can combine oral ovulagens like letrozole with gonadotropins. That also yields good results. Don't waste the cycle, because you want to, basically the target is to achieve pregnancy. Even whether it is post surgery or post coming to a practitioner, she should be pregnant in the next 1 or 1.5 years. So you have got a time frame in mind. In endometriosis, you are battling against time. So you basically want to, push harder. And of course, Dr. Hiral wanted to do IVF. Who wanted to do IVF? Somebody said I will proceed directly for IVF. Even that is an option, because we have some patients who come to us from metros, and probably they have done some self treatment or ovulation induction or whatever, and they said, madam, we don't want IUI, we just want to proceed for IVF, and they have read, they know about it, and they are basically puzzled with the whole thing. And in that case, we have to respect the individual decision. Purnima, what is your opinion?
Yes, ma'am. Ma'am, in these cases, the ovarian stimulation with IUI is the best option, be it oral ovulation or combined with gonadotropin. But yeah, so these are the best options in these
So
patients.
IVF is also not a bad option. And here the individual preference of the patient has to be kept in mind. If the patient is preferring an IVF and doesn't want to waste time in IUI, you have to proceed with IVF anyways. So, any role, suppose this patient is for IVF, and Varsha Lahade, madam, this patient wants a gap of 1 or 2 months before undergoing IVF. She's come to you in March, but she has a wedding in the family and she wants IVF in May. Would you do ovulation suppression, or would you give her a depot preparation, GnRH agonist, or anything? What is the evidence? When you're waiting for IVF, would you like
We should
to?
not give her.
Yes. And why? Why is that? Anybody can take the question.
Ma'am, as per guidelines, or as per the data, there is no as such any advantage of giving of ovarian suppression treatment for to improve the fertility before IVF, or if she's planning for IVF 2-3 months later.
There was a time, remember, about I think 7 or 8 years back, we were used to get patients of endometriosis. We used to regularly give GnRH agonists. Do you agree, Varsha ma'am?
Yes.
Regularly, we used to give GnRH
Previously, we used to
agonist,
suppress
one
it and
dose
then
or two
we used
doses,
to stimulate,
and then do her IVF. But
because
nowadays,
now the evidence doesn't say
yeah,
so.
you have to straight away proceed for IVF, or maybe do a fresh transfer or a frozen
A
transfer.
frozen.
That is a separate topic altogether, and no
Yeah.
need to wait for ovulation suppression. So can you continue the questions, Purnima?
Yes, ma'am. Ma'am, yes.
Yeah, you can read the guidelines.
Yeah, so in infertilized women with endometriosis, we should not prescribe ovarian suppression treatment to improve fertility. And operative laparoscopy could be offered as a treatment option for endometriosis associated infertility in stage 1 or 2 endometriosis, as it improves the rate of ongoing pregnancy. So we can go for the operative laparoscopy. We should not just do the diagnostic. Instead, we should also do the operative laparoscopy to improve the outcomes if we are planning the pregnancy in these patients after the surgery. And then FOXY GCPR is medical management in the form of ovulation suppression is ineffective in improving the pregnancy rates. And laparoscopy ablation or excision and radiolysis improve pregnancy rate in stage 1 and 2 when compared to diagnostic laparoscopy alone.
Yeah, so the primary surgery is very important, whether it is stage 1, 2, or early stage 3. Always do a careful ablation. I would not say yes to, because ablation will use energy, but careful dissection and careful excision and cystectomy with minimal bleeding, keeping the tissues, safe and respecting, give a lot of tissue respect. That is the best way. Preserve the ovarian cortex as much as possible. Try to have minimal bleeding. That is the key to a good surgery. And of course, here experience plays a big role. There are both the things. A youngster will learn only when she or he operates. A senior will think that they are experts, so the patient must come to us. But definitely there should be a balance. Unless the juniors do a surgery, they will not learn. So basically, it is a matter of practice when you start doing endometriosis surgeries regularly. So we've already dealt with expectant management or IUI. We will definitely not advise any expectant management in diagnosed cases of endometriosis. Always it is ovulation induction with IUI. Your experience with gonadotropins is what will help you in using them. So this is what is called as medically assisted reproduction, where you use controlled ovarian stimulation. Protocols with IUI. And now this is another case of infertility, and she is also 32 years, but she's married for 7 years, and she has already undergone 3 cycles of good controlled ovarian stimulation IUI. Then she stopped treatment for 1 or 2 years. Semen analysis is normal. Her AMH is now 1.5. And she has come to you with naturally expectations for maybe advanced treatment. But on TVS, you see a right ovarian cyst, which is 5 centimeter diameter with a ground glass appearance. So what are you going to do about this patient?
Ma'am, as you recently said that we should respect her emotions. Now she has undergone so much trauma since so many years. She is undergoing now EMH has come down to 1.5. We can give her an option to remove the endometrioma because it might increase her success for natural pregnancy.
Yes, yes, that is one of the indications for doing a good surgery for endometrioma, that it might improve the chances of a natural pregnancy. But now she is sick and tired of it. She's saying, ki, Madam, I don't want any IUI, and people have done 2, 3 IUI, I have not got result. I'm already 32 and my in-laws are after me for a baby, and I want an IVF. So how are you going to deal with the endometrioma if she is insisting for IVF, your patient? Will you like to remove this endometrioma, or would you proceed for IVF with an endometrioma? This is 5 centimeter endometrioma, quite large.
Proceed IVF
Ma'am, we
without
should
it.
remove the
At
endometrium.
first, we
To
give
remove the endometrium.
So if you want to remove the endometrioma, give me argument in the favor of removing the endometrioma.
There
no
are two
patient
schools
is
of thought here. 5 centimeter.
Removing the endometrium may increase the take-home baby rate.
Endometrioma, if you leave it like that, it will increase.
No,
Will decrease. If we remove the endometrioma, we can argue that that may increase the take-home baby rate.
You know what ASHRAE guidelines are saying about endometrioma nowadays? There are only 2 indications of removing the endometrioma.
And if we remove endometrioma, how would it affect fertility in ART?
You have to counsel the woman that when I'm removing the endometrioma, I may be the best surgeon in the city. But when I remove that cyst of the endometriotic cyst, after dissecting the cortex, you have to tweeze out the cyst. you are going to do some damage to the cortex.
Yes.
Some ovarian reserve is going to be, coming down. So you have to explain the patient of AMH 1.5 that later your AMH will maybe, it will decrease further.
Exactly.
So
You-
ESHRE has given only 2 indications where you should operate on an endometrioma before IVF. What are these 2 indications? Purnima, can you tell us?
Yes, ma'am. If endometrioma is too large and during the oocyte retrieval, it can cause problem for the oocyte retrieval, then we can remove this endometrioma.
Yeah.
And
Second is if the endometrioma is causing too much pain. The patient is in agony and she has to undergo IVF. So she's not able to get over the pain. She's having to take, NSAIDs. You can't give her hormones for suppression because you're going to take that patient for IVF. You're not going to give her COCs or progesterones or a depot preparation. If there is too much of pain
so,
or
ma'am, here is
yeah. And if that
ma'am, here is
endometrium
one.
is large enough to obstruct the accessibility to the follicles. In these 2 cases, ESHRE guidelines tell us we should remove the endometrioma, and I think this is there in the guidelines we have given it. Anything else you were saying, Purnima?
Yes, ma'am. I was just pointing it out that even if this endometrioma is causing problem during oocyte retrieval, you are suspecting that, then instead of removing endometrioma, we can just aspirate that
Drain the
endometrioma as well.
endometrium.
However, there is increased risk of abscess, which we have to keep it in our mind.
Again, I have gone through the guidelines very carefully, Purnima. They are saying that drainage and ablation, 2 things should not be done. Don't drain the endometrioma, don't ablate the endometrioma.
But most of the time, what happens is
That is
when they
during
go for an
laparoscopy.
ovarian retrieval, so oocyte retrieval, they accidentally puncture the endometrium. This is the commonest possibility.
Varsha,
So
I have
huh.
punctured endometrioma,
voice is
small endometriomas about 10 times in my
Okay.
career, about 10 times, small, like sometimes it happens in, even after
Yeah,
a
accident.
surgery. I have done surgery for endometrioma. Still, there are some tiny endometriomas which have not been excised during a
Exactly.
laparoscopy. So when we stimulate for IVF, the follicles form well, but 1 or 2 deep-seated endometriotic cysts are there. So when you do a pickup, occasionally that will be punctured, and in that tube, you will get that brownish fluid. Okay.
Correct.
So in that case, you have to flush the needle again with fresh medium. And probably that
choose
tube
the other side.
given to the embryologist that they will,
Okay.
either discard it or sometimes you might find an oocyte inside. You cannot discard it completely.
You never know.
But
Okay.
these patients, madam, I have just given routinely antibiotic oral tablets, 1 injectable shot. I have never found any ovarian abscess in my practice.
Wonderful.
So I think, madam, it is a lot of hype that you put a needle in ovarian
I know.
and you get an abscess.
Abscess, correct.
Because getting an ovarian abscess in your practice, I have yet to find people who say that we got ovarian abscess by doing this. So yeah. So now before and after surgery for
Say that
endometriosis,
every surgery.
yes, you have to counsel the patient objectively on the subsequent chances, especially about diminished ovarian reserve. So leave it to the patient and your acumen, your counseling, it has to be very proper. And if you really find a huge endometrioma, which is totally going to obstruct the follicles, then it is better to operate upon her, probably give a minimum gap and then start stimulation. So this is what literature is saying, that a cystectomy or cyst wall excision is much better than drainage and coagulation. You should avoid energy sources. You should avoid, because draining will just drain and everything is the same. That place will seal again and the collection of the blood will be there once again. So drainage is not advised, but if you have to do an emergency drainage just for the pickup, that depends upon the individual. I don't do it and I've never done it. And we will definitely like to discuss it with other senior people whenever we can. So no role of ablation. Any role of pre or post-operative adjuvant medical therapy with surgery?
In infertility patient, no role. And in case of adolescent girls, or in case we give the medical management later on to decrease the recurrence rate.
Yes. A post-operative medical management is especially advised if you do not want a pregnancy very early. In that case, you can give a post-operative medical management in order to, prevent the recurrence of the disease. Now, again, this is the repetition of the same thing. Can you read the guidelines, Purnima?
Yes, ma'am. Excision of endometrioma, that is cystectomy, is recommended to increase the spontaneous rates, pregnancy rates instead of drainage and coagulation. GDG recommends clinicians should not prescribe adjunctive hormonal therapy before surgery to improve spontaneous pregnancy rates, and clinicians should not prescribe adjunctive hormonal therapy after surgery to improve spontaneous pregnancy rate.
Yeah, so adjunctive hormonal therapy will only be used in those patients who do not want pregnancy immediately, or in probably, adolescents or young women who are not wanting a pregnancy. And of course, post-operative hormone treatment also serves the purpose of reducing pain, especially in those women who do not want immediate pregnancy. So now there is a paradigm shift. I was in a panel in Bhopal Obs-Gynae Society about 5 or 6 years back, where I was speaking in terms of operating on endometrioma, and there were about 60% panelists who were speaking no, because that time I was very much unaware that we were all pro-surgical people. But in those 6 years, the paradigm shift has occurred from surgical to conservative, and wherever possible, we want to conserve the ovarian cortex. Clinicians are not recommended to routinely perform surgery for ovarian endometrioma prior to ART, as current evidence shows no benefit and surgery is likely to impact ovarian reserve negatively. But surgery can be done, number one, to improve the pain factor, and number two, to make the follicles more accessible. These are the two guidelines which ESHRE has given us. Anybody would like to talk about endometriosis fertility index and what is it and how is it calculated, though it's slightly difficult, but anybody who has an idea how to do it?
Ma'am, it includes patient factors as well as surgical factors.
Yeah.
Like you need to take age, AMH, staging,
So those are called
endometrial
historical
cavity,
factors.
tubal patency.
Those are called historical factors, है ना?
Historical.
History wale. And second is
Yes,
called surgical
patient
factors.
factors.
Yeah. Yeah.
Surgical factors.
Yes.
And surgical factors, you need to know about the function of the tubes, ovaries, and the lesions of endometriotic patches. And the score has been done by that our revised ASRM staging. As per ASM, we need to score it between 0 to 10.
So what about EFI? I understood and I like to teach is that endometriosis is basically for this arriving at EFI score, though there is conservative method of knowing EFI now by ultrasound also. But the traditional EFI, which was started in 2010 by Adamson, was that you have to first operate, and at the end of the surgery, you have to take out a score. And that score is prediction of those pregnancies which can occur without ART after surgery, preferably within a year. So how much is the chance of a patient getting pregnant without ART at the end of a surgery in which you have taken out a score called endometriosis fertility index? And these are all added up. So this was found to be very validable, reproducible, and cost effective. This has got patient-related factors called historical factors. This has got a surgical factors. This takes out LF score, that is the least function score, and the score is generated between 0 and 10, which strongly correlates with the post-operative non-ART pregnancy rates. So this is the only score which is supposed to be very good, and there are whole articles on this. It's never ending. So anybody who's very, very passionate about endometriosis can go through this score and inculcate in practice. Of course, Sujata ma'am has talked about it. So she is a very, very busy practitioner. I've always found her busy in OT, Dr. Sujata Kar, but still she has time to do the EFI. This means it can be done. So can you tell us about two types of EFI, Purnima? One is type A and one is type B.
Yes, ma'am. The type A is based on non-surgical or clinical or ultrasound findings only. And the type B is based on the combination of non-surgical clinical ultrasound findings and diagnostic laparoscopy as well. So the score which we talked about was type B.
Yeah, but nowadays, even
Surgical
with good ultrasound, you can take out EFI, and we would like to
type
discuss it
A.
anytime further when we have time. We'll be probably knowing which is better and how we can make it an instrument to guide joint physician-patient decision making between query surgery, query ART, and other options. And basically, this will help us to individual. Now that nowadays, all treatment, whether it is PCO or it is endometriosis, or it is poor responders, it is individualization, individualization, and individualization. So basically, we have to just keep ourselves updated, and still any patient who comes to you, even after 20 years of practice, might surprise you with some different presentation. All have seen what is the effect of endometrioma on ovarian reserve. Anybody has experience of doing AMH after endometrioma surgery?
Yes, ma'am.
Yeah, AMH,
How
AMH
before
recover within
after endometrioma surgery, how much a time after the surgery you should do AMH, and what difference have you found, Dr. Hiran? Tell me.
Ma'am,
after
ideally
6
it should be
months.
done after 3 months, but I have done in my student after 6 months. And before surgery, her AMH was 4.25. Then she was operated for ovarian endometrioma, and her AMH declined up to 3.6.
Okay, 3.6 and 4.25. Don't you think it's like not very, very significant? Like the prognosis
Yes,
you,
ma'am.
yeah.
Yes, ma'am. It has no prognostic or anything value, but just for the curiosity, because she was a gynec resident, she wanted to know her AMH. So for that purpose, we did AMH.
Yeah, yeah.
She was a resident in the Medical College of OBGY, so she wanted her AMH to be repeated after 3 months and 6 months. So there was no significant decline we have seen.
And you would be surprised to know that I just attended last month a conference called Genesis in Jaipur, which is a very focused conference of ART practitioners with the latest guideline. The speakers from Europe, they come for a focus. It's not a very common conference. Some special invitees are there. So there we listened to Sesh Sunkara and Professor Nicolets. They said even AMH values, they differ in various types of the menstrual cycle. So the AMH you will get in the proliferative phase is definitely different from the secretory phase. From mid-cycle, it is different. So whatever we know about AMH, there might be variation. We like to think that AMH is not affected by OCs, it is not affected by stress, it is not affected by phases of menstrual cycle. But you read the latest literature, AMH also has variations. So this is all about AMH, and whether you want to do it or not, I don't know. But personally speaking, after endometrioma or excision or cystectomy, I would straight away plan for a good IVF and not waste time in doing any AMH. So this is again the number of oocytes and the number of M2 oocytes were significantly lower in those women with endometrioma versus control. And all other outcomes in an endometrioma patient, including gonadotropin dose you use, duration of gonadotropin, the number of good qualities embryos you get, the clinical pregnancy rate and the live birth rate are similar, whether you remove the endometrioma or you don't remove. So the protocols, anybody would like to put in a last word about the protocol you would use in this patient, antagonist or agonist? What is your favorite protocol? Anybody still using long protocol? Varsha madam?
Sapna madam is there.
Ma'am, long GnRH agonist we are using.
You're getting good results as compared to antagonist?
Yeah, ma'am. In one of my patient with severe dysmenorrhea, I used long GnRH agonist, and I was planning of IVF. She said after 3 months I will see, but before 3 months IVF she was pregnant naturally.
Okay, you used GnRH agonist long acting after surgery.
No, after surgery.
After surgery, you gave her 3.75 mg of
Yeah,
leuprolide?
yeah, ma'am.
Okay, okay. But evidence says that you should not give any sort of ovarian suppression after surgery. But definitely, if your woman, if your patient wants a gap before IVF or she wants to try for natural conception, then naturally you can give a gap. But giving a long-acting agonist just for the sake of preparing for ART cycle is definitely not advisable, Dr. Sab.
Good.
Yeah. But I also have that
Ma'am,
experience.
I would like to leave. I've got an emergency.
Yeah, yeah, please, please.
Okay.
So, can you summarize, Dr. Purnima?
Yes, ma'am. So repeat surgery for endometrioma is not recommended for fertility improvement. And indication for repeat surgical treatment are mainly severe recurrent pain symptoms that impair quality of life or treatment of symptomatic endometrioma. And previous ovarian surgery result in longer stimulation, higher FSH requirement, decreased oocyte number, but no difference in fertilization, pregnancy outcome, and in subsequent ART cycles.
I'm sure all of you must have seen endometriosis patients where they have undergone primary surgery 5, 6, or 7 years back, and they come to you with a bigger endometrioma. They again come to you with endometrioma. Have you seen such a patient, Dr. Richa, and what would you do? She's giving you a history of endometrioma surgery. Okay, you are seeing another endometrioma after 5 years. She
Yes.
is, yeah. So would you like to touch that patient, do a resurgery?
No, not at all, madam.
Not at all. Patient will not allow.
Also, a resurgery is always an absolute no, and that is the reason we say only if you are a very, very good surgeon and you are very confident, only then you should touch the endometriosis patient for the first time. When you are doing it, only do it if you are very confident that everything will come out very absolutely correct.
You
Because
don't
you are only spoiling, and moreover, as far as I don't know, I missed out the beach may things you must have talked about already about
Yeah.
the ovarian.
We talked a lot about the surgery part. We talked about, conservative management vis-a-vis endometrium cystectomy. Definitely the cystectomy has to be good, and this repeat surgery becomes a big task, and anybody would agree that it becomes very scary for the ART practitioner. It's better whatever tissue, ovarian tissue you have, you stimulate or because I had a patient who, for whom 15 years back, I did endometriosis cystectomy. She conceived in the first IVF cycle. Then she came to me when her son was 10 years old. After that, I just found she never was free from endometrioma, always bilateral endometrioma, chocolate cyst, pain, agony. And then when she turned about 37, 38, and she still wanted a child, I had to advise her, oocyte donation cycle, but she refused. So that is the stage, like if they give too much of gap, that endometriosis comes back with a huge vengeance and it becomes worse and worse. So that takes us to the end of the panel. We definitely give our huge respect to William Osler because he has told us that everything you want to know about gynecology, endometriosis will teach you. It will teach you counseling. It will teach you patient psychology. It will teach you about the best analgesia in gynecology. It will teach you the best surgical techniques, staying free from energy. It will teach you how to respect the ovaries and, uh, improve your surgical skills. It will also tell you how to differentiate the masquerading endometriosis from other things like PID or FGTB we have discussed. It has told us about biomarkers, which are the future for diagnosis. It is also going to tell you about certain genetic things about endometriosis which run in families. And another big thing which we have not discussed besides recurrence is malignancy, the occurrence of malignancy, because there was a slide in one of the speakers of this webinar where they said that in recurrent endometriomas, 9% turn into malignancy.
9% chances are there, yeah.
Yeah, so this is another thing we have to consider because I was just discussing in my family in last 20 years, I have seen 5 malignancies. It's a lot, but I have seen. Yes, so 5. So every family is now, because better diagnosis, maybe, but 2, 3 cases were such that because of, because cigarette smoking or this thing, extended family. But there was one incidental case of renal cell carcinoma in a person who had absolutely no addiction, no nothing. So this tells us that these malignancies are also increasing in our world in this era. And you can see from the loads of work that onco surgeons and onco physicians are doing nowadays. So how much this endometriosis is going to be related with malignancy in the future, that is also a big question mark. So thank you all for a wonderful panel. If there's anything else you would like to comment, any of you, you're most welcome. Otherwise, we wind up.
We'll
Thank
take
you,
a photo
Monica.
together.
Yeah.
Thank you,
So
Monica, for
we'll
giving me
we'll
opportunity.
stop the share and
This
we'll
was
yeah.
beautiful.
Wonderful, Monica. It was wonderful panel.
Best moderation.
Thank you, ma'am.
Thank you, madam. Thank
And
you.
I love that concept of reading the consensus to
Yeah.
come to the conclusion. Yeah, lovely.
Thank
Nice.
you, Pratibha ma'am,
Thank you,
for the
ma'am.
opportunity.
We have learned
Thank
a
you,
lot.
Pratibha ma'am. Thank you.
And this
You
webinar
have
was
done
only
the
possible
full
because of
you have
this
done the full
webinar.
revision of these guidelines. It was wonderful. Very nice. Very
And
nice.
Pratibha ma'am, I'm totally indebted to you for this opportunity of your wonderful committee, your wonderful presence.
Thank you,
And
sir.
I cannot thank you enough. My panelists have been wonderful. And
Yeah.
my coordinators, Purnima and Manisha, have given me all the support. Dr. Vishal is always there besides us to give us support from INTAS. He's the medical director of INTAS. And of course, the tech support by INTAS Pharma. Thank you so much, madam.
Thank you, mom.
Thank you,
Thank you,
everyone.
Pratibha
Thank you.
ma'am.
Thank you. Thank you, sir.
Bye-bye. See
And
you.
this YouTube will this webinar will be available on YouTube in 48 hours or 2-3 days, and we will share the link with everyone.
Okay.
Thank
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 you.
you, Monica. Thank you. Wonderful.
Thank you,
Bye-bye.
ma'am.
Sorry, ma'am, had to leave in middle because of some emergency.
Oh, dear Richa, your inputs were great. Totally. Thank you.
Thank you so much, ma'am.
Thank
Thank
you.
you, ma'am. Thank you. Good
Bye.
night.
Good night. Good night.